we'll get the meeting started. I'd like to welcome everyone to the Texas Higher Education Coordinating Board Committee on Academic and Workforce Success. Please be advised that this meeting is being broadcast over the internet. Agenda item 2 is consideration of approval of the minutes from the June 20th, 2018 committee meeting. Any questions or discussions about those minutes?
Move that we accept the minutes.
Second.
Okay, we have a motion from Mr. Wilson and a second from Mr. Raven. All in favor, please signify by saying aye.
Aye.
Any opposition? Hearing none, the motion passes. Agenda item 3 is consideration of approval of the consent calendar. Items listed on consent are items 5O, P, T, U, 1 through 5, and V, 1 through 6. Any discussion? If there's no discussion, do I have a motion?
So moved.
Second.
Motion by Mr. Raven, second by Ms. Acosta. All in favor, please signify by saying aye. Any opposition? Hearing none, motion passes. Agenda item 4 is public testimony on agenda items relating to the Committee on Academic and Workforce Success. We do not have anyone registered to testify, so we will go on to the next item. Item 5 involves matters relating to the Committee on Academic and Workforce Success. 5A is a report to the Committee on Activities of the Certification Advisory Council. This is for information item only. The Certification Advisory Council's chair could not be here today, so Rex Peebles will do an update on these activities.
Well, thank you and good morning. So our long-running chair, Donna Jurek of St. Edward's University, finally retired after threatening to do so for ever since I've known her. That's been quite some time. But she finally retired, and so she opted out of this meeting. The Certification Advisory Committee exists to advise the coordinating board and make recommendations on institutions that fall into that category of what we generally refer to as Chapter 7 institutions, and those are profit and sometimes nonprofit institutions that operate in Texas that are not public institutions and are not a part of the independent colleges and universities of Texas system, or institutions that are headquartered outside the state of Texas that wish to operate in the state of Texas. And one of their primary functions is to review certificates of authority. And those are the cases in which an institution comes to the state of Texas and wishes to establish a higher education institution here, but they do not have accreditation from one of our recognized accreditors. That usually means they're brand new and they're just getting started. And so in many respects, the coordinating board acts as the accreditor for that institution for up to 8 years. But they review those proposals before they come to the commissioner and to the board for final approval. And they reviewed one program this past year, and that was the United States American College of Business and Healthcare, which is located here in Austin and had formerly been around for many, many years. And y'all approved that program in, I believe it was the April, or May, I guess it was the May board meeting.
Okay.
I'll leave it at that.
Thank you. Next, agenda item 5B is a report to the Committee on Activities of the Graduate Education Advisory Committee. This is an information item only. Dr. Andrea Golato, Vice Chair of this committee, will provide a brief update of the activities. Welcome.
Thank you. Can you hear me?
Can you press the red button?
I did.
Perfect. Now.
All right. Wonderful.
Thank you.
All right. So the Graduate Education Advisor Committee, or GEAC, advises the agency staff and board members on procedures, issues, and long-range planning related to graduate education. The chair and vice chair in 2017 were actually Dr. Meharban Sani Singh from the University of North Texas Health Science Center and Karen Butler Purry, Texas A&M University. And there's a membership of 24 graduate deans, faculty who teach in graduate programs, and others who are closely related in oversight of graduate education in Texas. And they come from a range of public institutions, but also private institutions. And we have one student member. And during the last academic year, the committee had 3 meetings, and we also had subcommittee meetings. And we focused on 3 main themes during this particular year: on the marketable skills, on characteristics of doctoral programs, and on the strategic plan for graduate education in Texas. So for marketable skills, the discussions focused on the fact that when institutions specify marketable skills, that they ought to be different for graduate students than for bachelor students, and that there should be different skills in place for master's students versus doctoral students. And the committee as a whole was not only interested in identifying these skills, but also ensuring meaningful ways for students to obtain these skills. And it was reported that many graduate schools in Texas are already partnering with career services and other offices on campus to provide training for students to be aware of and to be able to articulate their marketable skills. And the committee also recommended to include marketable skills into the strategic plan for graduate education. The second topic we focused on were the characteristics of doctoral programs. And these characteristics of doctoral programs were revised from the 18 characteristics to simply characteristics. And this reflects the fact that the number and components of characteristics may change over time, and that the name may just 18 characteristics may not be appropriate if you have fewer or more than 18. And this fall, we will also start to include data not just for research degrees, but also for professional practice doctoral programs. And so the characteristics have been reorganized into those that are required for all programs. So for example, characteristics such as the numbers of degrees awarded, the time to degree, et cetera. And then those that are just for research, for example, student publications wouldn't be appropriate for practice doctoral programs, and then just those for professional practice programs. For example, the number of students who are passing licensure exams, et cetera. What the committee really spent most of its time on over the past year was the strategic plan. As you may know, not many states have a statewide strategic plan for graduate education, and so this is an opportunity for Texas to have nationwide impact. And the challenge that the committee saw was that we need to guard against making the strategic plan too generic, and so that it lacks meaning, while we at the same time need to accommodate the different types of institutions that we have, and not and so accommodate all of those. So we can't be too restrictive in what we include, so that elements that are relevant to HRIs or masters-only institutions are also considered. So the committee as a whole brainstormed on a variety of different topics to be included. There was a subcommittee that we created that prepared a draft, and then the subcommittee, agency staff, and the whole committee worked together in a number of meetings to develop a preliminary draft. And the plan focuses on 5 priority areas. The first priority area is, it's 4 priority areas. Excellence in research and creative activity, high quality of and access to education, efficiency and innovation, and marketable skills and promoting economic development. And for each of these priority areas, we have established a number of goals and also suggestions on how to measure progress towards these goals. The plan is currently with agency staff for finalization and review. And that's it so far.
Any questions for Dr. Galato? Well, thank you for being here, and please send your thanks to your committee.
I will. Thank you.
Thank you. Next, we move on to agenda item 5C1. That is consideration of adopting the staff recommendation to the committee relating to the request from Angelo State University for a bachelor of science degree with a major in mechanical engineering. Rex?
So Angelo State proposes to offer its second engineering degree, this one in mechanical engineering. It's a 127 semester credit hour program to be aligned with ABET criteria, for which they will seek accreditation once they achieve their first graduate. The Texas Workforce Commission anticipates mechanical engineers will experience a 17.2% increase in employment over the next 8-year period. And mechanical engineers also have one of the lowest unemployment rates at 1.1%, among professions, which is indicative of the fact that mechanical engineers often find employment outside of mechanical engineering per se. I'd like to point out that the program is also supported by a $2.75 million culturally responsive education in mechanical engineering grant from the U.S. Department of Education. And so Angelo State deserves some kudos for being able to secure that money and that kind of funding that goes with it to help support this program. They anticipate 5-year cost of approximately $3.4 million and funding of $4.8 million.
Okay. Do we have representatives here?
We
If
do.
you could please come forward. Thank you. Dr. Brian May, the president of Angelo State University. Welcome. Dr. Donald Topliff, vice president for academic affairs. And Dr. Paul Sweat, the dean of the College of Science and Engineering. First of all, thank you all for being here, and we'll start with Dr. May. Would you like to say a few words?
Majors, excuse me, maybe I should say, we got 600K on the side, but we already have 200 majors in civil engineering, and we're very proud of that fact that in December we have our first 5 graduates in civil engineering that will come across the stage, and it's a big thing for Angelo State University. It really takes us to a new level. One of those graduates comes from the Eagle Pass campus of Southwest Texas Junior College. Through the HSI grant, we were able to involve the border of trying to bring engineering, which is sorely needed in that area. And upon graduation, this student is returning to the Eagle Pass area, taking engineering back. That, to us, closes the loop. We're very proud of that fact, and we're going to make a big event of it during graduation in December. Mechanical engineering, of course, is, as Rex pointed out as well, we're on the edge of the oil and gas area, big major draw for mechanical engineers. Really, there's many students in our area that would have no chance of being in engineering were we not able to offer it. We have an outstanding foundation called the CAWS Foundation. It's 138,000 acres of oil and gas royalties that goes used only for scholarships. And we use that, and these engineering students are able to take advantage of that. But working with Southwest Texas Junior College at Uvalde, as well as Eagle Pass, is a big portion of that. So we appreciate the support that we've had from the coordinating board in moving this forward.
Very good. Dr. Topliff.
I would just add that we have already hired 2 mechanical engineers for the program, and so we're ahead of schedule what was required by the coordinating board. At the current time, we're also advertising for 1 additional position. So I would say that we're 2 years ahead of schedule. The other thing I'll point out is that civil engineering didn't start on our campus until 2015. So 3 years in, we're going to have the first 5 graduates. We already have the first draft of our ABET accreditation report, and actually Dr. Kitch, who is the chair of the department, is a program evaluator for ABET, and so he is well aware of all the accreditation requirements. So we're very confident that that by the summer or by next fall that we'll have the ABET visit, and that by the following summer we'll have ABET accreditation for civil engineering. And we think that the accreditation for mechanical engineering will follow there shortly after. Again, we appreciate the support of the coordinating board. The last thing I would say is that one of the issues that we face in our region is that attracting mechanical engineers from other regions of the state, other schools, and keeping them in our region is difficult. And we've provided documentation in our proposal to that effect that firms that hire mechanical engineers in our region have a hard time retaining them. They're not, as we like to say, they're not geographically acclimated to West Texas. And so we think that that is a key reason that we need this program. So again, we appreciate the support of the board. Thank you.
Thank you, Dr. Sweats.
I'd like to add to what my boss has said. We have approximately 30 existing engineering students who would like to transfer and become mechanical engineers. If we want to keep them at Angelo State, we would be very thankful to have this program. We appreciate the board's support to help educate these students in West Texas.
Great. We thank you all for being here, and thank you for the great work at Angelo State University you continue to provide for the region and for the state. I'll open up to any questions or discussions from the board. Mr. Raven?
Mr. Chairman, thank you. Dr. May, could you talk a little bit about this CREAM grant? Is it a part of that grant that your students have to stay in the area? Can you tell the committee a little bit about that?
Yes, that's exactly right. That would be focusing in on, because it's a HSI grant, it would be focusing on the demographics, which are primarily Hispanic, and we're a Hispanic serving institution. About 37% of our students are Hispanic, and it grows every single year. And this allows us to work with them on retention and graduation rates, getting out on time, but it also gives them opportunities that they would not have, because most of those students are very close-knit in the family culture and want to stay at home. But being able to let them enjoy this incredible financial support we have as well, we make it very affordable for them to get an engineering degree.
Well, thank you. Job well done.
Thank you.
Any other questions or comments for the panel? If not, do I have a motion to adopt the staff recommendation?
So moved.
Second.
Motion by Mr. Raven, seconded by Ms. Acosta. All in favor, please signify by saying aye.
Aye.
Any opposition? Hearing none, the motion passes. So thank you all for being here. We move on to agenda item 5C2, and that is consideration of adopting the staff recommendation to the committee relating to the request from the University of Houston for a Doctor of Medicine degree with a major in medicine. I'd like to call up the University of Houston, Mr. Peter Taffy, Vice Chairman of the U of H Board of Regents, as well as Dr. Paula Myrick-Short, the Senior Vice President for Academic Affairs and Provost for the University of Houston, and Dr. Stephen Spann, the Founding Dean of the College of Medicine and Vice President for Medical Affairs. If you can please move forward. Members, you have supplemental materials for this item in the gold packet here that has been provided for us. Welcome to Mr. Taffy, Dr. Short, and Dr. Spann. Dr. Taff, Mr. Taff. Thank you. Thank you, Ricky. Okay, so at this point, Rex and Stacy will be presenting this item. Dr. Silverman. Okay, we'll have, first of all, Dr. Short. Or would you like the Board of Regents Vice Chair, Dr. Taffy?
Sure,
okay.
I'll be quick.
Sure, welcome.
Thank you very much. So on behalf of the University of Houston, I'm here to serve as Vice Chairman currently, having succeeded Mr. Wilson, and also with me is Durga Agarwal, another member of our board. Obviously, we're very much in support of our medical school proposal, and I'll turn it over to the professionals here to give you more details on that. Thank you.
Dr. Short, welcome. Good morning.
Thank you so much. As you're aware, the University of Houston is a comprehensive Carnegie, very high research university. And as such, the university has had a long-term emphasis and interest in health care, both through our programming, our research, and our outreach with our students, with our faculty, with our undergraduate, graduate, and our doctoral level programs at the University of Houston. We have many health-related programs at the university to support our emphasis on health, such programs as biology, chemistry, and other biomedical science programs. So the university has had a long-term involvement, a long-term interest, and a long-term focus on health and health care. You might be interested in knowing that of our health-related schools on the campus, our College of Pharmacy was founded in 1947, and our College of Optometry in 1953. Our Graduate College of Social Work in 1968. And even though our College of Nursing is relatively new, 2015, I think those dates give you some idea of the long-term work and the long-term involvement of the University of Houston in the area of health. We have programs that help our students move in to health-related careers. We have a relationship with the William E. DeBakey High School for Health Professions through our Houston Pre-Medical Academy through our Honors College. We also have 10 conditionally offered slots through the Baylor College of Medicine that guarantee admission for our students should they want to enter medical school. So the university has a strong vision and a strong mission to be relevant to our community, both the larger community, the city of Houston, and particularly in the area of health. It's one of our, what we call big rocks. We have 3 big rocks at the University of Houston that give us a major foci on what we do: arts, energy, and health. We have intensified that interest and that work in the area of health through new research centers, through engagement with the Third Ward, our community, many activities that our health-related colleges engage in, connecting to the community. And with the diverse city that we live in and the demands for health and health care of our community, particularly the improvement of health outcomes. Our leaders at the University of Houston, our faculty, and our students believe that we can only relate in this unique role of addressing health disparities with the establishment of a medical school which focuses on the preparation of primary care physicians. So with that as a foundation for why this is so important to the continued growth and development and the vision and mission of the University of Houston, I'm going to call on Dr. Spann to give you how we plan to do that.
Thank you, Provost Short. It's a real honor for me to be with you this morning. I am a family physician by training and practice. I've spent most of my career as a medical educator. I've had the real privilege over the last 3 years to be involved from the very beginning in the planning of this new medical school, and I'm excited to be able to tell you about it this morning. Now, I'm sure one of the first questions that would come to your mind is, why does Houston, which has 3 great traditional medical schools, need another medical school? And I would like to convince you that there are a number of reasons for that. I think we're all aware that as a country, we struggle with the value of health care. Compared to other wealthy countries, the cost of our health care is the highest in the world, and the quality is not the best. If you look at Texas as a state, the quality of our care compared to other states, the outcomes of care, is relatively low, while the cost is significantly high. Now, there's been a lot of research on the causes of low-value health care. Some of it has to do with health care per se, poor access, weak primary care, poor coordination of care. But we now know that a lot of that is due to what we call social determinants of health, including unhealthy lifestyles, poverty, poor education, and in addition to that, profound socioeconomic and health disparities. And Houston is no exception to that. This map, which was put together by Dr. Stephen Linder at the UT School of Public Health, shows the relationship between socioeconomic disparities and health disparities. And what you see here is a crescent-shaped area of geographic communities in our county with major socioeconomic disparities, and most of those areas have significant, profound health disparities, with health indices often comparable to that of developing countries. And right in the middle of that crescent sits the largest medical center in the world, the Texas Medical Center, a wonderful medical center where I trained and taught and served for many years. But we still have profound health disparities. We also, as a state, have a shortage of physicians. We rank 41st out of 50 states in terms of total physician to population ratio, 47th out of 50 in terms of primary care. And if today we wanted to match the average primary care physician to population ratio of our country, today we need 4,600 additional primary care physicians just to reach that national average. And there's very strong evidence from national and international studies that strong, robust primary care improves health outcomes and decreases costs, therefore improving value of care. Another challenge we face in our state, as does most of the country, is that our physician workforce doesn't reflect that the ethnic makeup of our physician workforce doesn't reflect that of our population. Now, the last new medical school in Houston was started in 1972, which was the year I started medical school at Baylor. The UT, now called McGovern, was started in 72. Since that time, the population of our area has essentially tripled, and yet no new medical schools. And despite the fact that we're in the city with the largest medical center in the world and have 3 wonderful medical schools in our region, we still have, as you can see here, significant geographic areas that are medically underserved and primary care health profession shortage areas, according to HRSA data. So we would make the case that there is a need for an additional medical school in the city of Houston. We have developed a mission statement for our school, which you see before you, and I just want to emphasize some of the key points to that statement. We want to be accountable to society for improving health and health care of the population in our city, in our state, and beyond. We want to educate physicians. That will be the primary mission, a diverse group of physicians. And we want those physicians to focus on primary care and other needed specialties such as psychiatry and general surgery. Our goal is that 50% of our graduates would enter primary care specialty practice. Research is an important mission of medical schools. We want to have great interdisciplinary research, but as opposed to focusing on disease, such as how to cure cancer, we want to focus on how to improve health and health care. Medical schools provide health care, deliver care, and we aim to provide integrated, evidence-based, high-value care through interprofessional teams. And finally, medical schools serve their community, and our goal is to really engage and partner with those communities that have major health disparities to improve their health and health care. We have a vision to be recognized in the future for the kind of physicians we train, for graduating physicians who practice primary care and other needed specialties, for training a diverse group of physicians, for conducting important research, for delivering excellent care through interprofessional teams, to engaging and working with communities that have health disparities to improve their health, and to really contribute to measurable improvements in the health of the underserved populations in our area. So many people would say, well, you know, most medical schools don't succeed in training primary care doctors. In fact, the figures both statewide and nationally are that only 20% of our medical school graduates choose primary care. So you might say, well, how are you going to achieve 50%? There are some schools that are achieving that. We have visited them. We have borrowed from their best practices. And here's what we've learned. First of all, a very holistic admissions process that goes beyond a focus on grade point average and MCAT scores to look holistically at the applicant, at their background, at their leadership, at their community service, at their family of origin. There are a number of known predictors of primary care specialty choice that can help guide the admission of students who are more likely to choose primary care specialties. A curriculum that really emphasizes primary care in its breadth and depth, a culture that values primary care. How many times in my career as a medical educator have I had students come to me and say, you know, Dr. Spann, I was thinking about going into primary care, but my professor of X, subspecialtyologist, told me I'm too smart to be a primary care doctor. Well, since I am one, I happen to think that being a great generalist primary care physician is one of the greatest intellectual challenges in the world. A culture, a faculty that values primary care. And it is true that one of the challenges to medical students today as they consider their specialty choice is that of debt. When the average U.S. medical school graduate has $190,000 in debt, and they face choosing primary care versus a procedural specialty that pays 2 to 3 times as much, they often do vote with their wallet. So we have to find ways, we think, to scholarship, to provide loan repayments to decrease that debt. So how will our medical school be different? You can see here a number of areas. Our curriculum will have a strong emphasis on community and population health, primary care, behavioral and mental health, etc. Highly integrated curriculum, a lot of emphasis on interprofessional education involving students from our nursing, pharmacy, optometry, social work schools. An emphasis on adaptive education, adapting our teaching methods to the learning styles and needs of our students, and adapting our curriculum to the health care system changes over time. We will have a longitudinal primary care experience in which students will spend a half a day a week in a primary care setting every week of medical school for 4 years. That's very unique. And 1 week a month, they will not be in the primary care clinic. They will be out in households of patients, families with complex medical social problems living in underserved communities, with a team of other interprofessional students, including nursing, pharmacy, social work, providing what we call household-centered care, following those families longitudinally over 4 years to learn all about social determinants of health and how to help people navigate our complex healthcare system. And we will have a strong emphasis on social determinants of health and health disparities. Our curriculum involves a 19-month pre-clerkship curriculum that is integrated organ-based in its approach. There will be the usual courses in biomedical sciences. We will have a longitudinal course in what we call physician, patient, and populations, which will teach a number of subjects together, including population health. There will be a longitudinal primary care clerkship, as we have discussed. There will be periodic clinical focus sessions, a week long, with important topics, and will last about 19 months, culminating in a special transition to clinical clerkship boot camp. You might be interested to know that the LCME only allows students to be in class or clinic for 20 hours a week during their first 2 years of medical school. Only 12 hours of that week in our curriculum will be spent in basic sciences. They'll have 4 hours of the physician, patient, and population course and 4 hours of longitudinal clerkship. The rest of their time is available for them to study and do a lot of self-learning. In the clinical years, our clerkship year will be unique in a number of ways. Half of that year will be spent in what's called a longitudinal integrated clerkship, in which instead of being based in the hospital, the student spends half a day a week for 24 weeks with each of the major specialties such as medicine, pediatric surgery, OB-GYN, family medicine, psychiatry, and neurology. Then there will be 5 4-week inpatient, in-hospital rotations in medicine, surgery, pediatrics, OB-GYN, and emergency medicine, and a required 4-week clerkship in rural health so that the students have in-depth exposure to the experience of caring for patients who live in rural areas. There'll be a number of opportunities for electives, time for scholarly concentrations and research. In the last year, the final year, they will be required to spend 4 weeks on an inpatient ICU, critical care rotation, and 4 weeks on an inpatient sub-internship. And at the end of the 4th year, they will be involved in a 2-week, what we call boot camp, to prepare them to enter their residency programs. We have a number of clinical partners that we have developed to provide places for the clinical learning experiences. Our key clinical partner is HCA Healthcare Gulf Coast Division. HCA now has the largest hospital system within our region, and they are going to partner with us both in medical student education and graduate medical education. And I'm pleased that my colleague, Dr. Stephen Nesbitt, who is the Chief Medical Officer of HCA Gulf Coast Division, is with us today. 5 of their hospitals will be used for medical student education. You can see them on this map. I know that it's very difficult to see. We also have a memorandum of understanding with St. Joseph Medical Center as well as MD Anderson to provide additional medical student rotations. We have a number of affiliations with federally qualified health centers and other safety net clinics to provide places for that longitudinal primary care clerkship. And so I think that the capacity that we have to train students in the clinical arena is substantial. Finally, I want to talk about our plans for graduate medical education. We are developing in partnership with HCA a graduate medical education consortium. It will be called the HCA GME Consortium. This consortium will develop 6 new residency programs in medicine, pediatrics, surgery, OB-GYN, family medicine, and emergency medicine, plus a transitional year program. The first programs will roll out in 2019, and additional ones will be added over time, as you can see here. This will ultimately contribute to 142 new first-year resident positions, and after those residencies are completely full, we will have 389 total new resident positions. So we will meet and exceed the legislative mandate to provide 110% as many new first-year positions as the ultimate size of our graduating class will be 120. So we will exceed the 132 by 10. And this is a substantial contribution to graduate medical education in the state of Texas. The cost, the estimated cost of the 5-year startup for all of these programs, calculating $150,000 per resident per year in cost, adds up to $230 million. So this will be a substantial contribution of our partnership to graduate medical education in the state of Texas. I think we have a bright future. I think that we will provide excellent training for medical students, excellent training for graduate students, and I appreciate the chance to tell you about this exciting vision. Thank you very much.
Thank you, Dr. Spann. Next, before we take any questions or comments, we're going to listen to the staff. Next, Dr. Silverman and Dr. Peebles.
Okay. Oh, thank you. Well, thank you so much for letting me talk to you this morning, and I'm here to talk about the staff perspective on the University of Houston's proposal. Let's see if we can make this go right. So the staff recommendation is approval with 2 additional recommendations. The proposed program would likely provide physicians who would enter primary care specialties and allow them to pursue careers in geographically underserved areas. The institution has 2 goals. You heard about one this morning. It's to have 50% of its graduates practice primary care. The other is its focus on underrepresented populations. The proposed budget is a mix of general revenue, including special item funding, tuition and fees, and institutional reallocation, also donations. U of H has strong supporting academic programs. It's got existing faculty in place. It's got a physical and administrative infrastructure necessary to develop this kind of proposed program and ensure that it's a high-quality program. The institution submitted a specific plan. You just heard Dr. Spann talk about it, about the creation and the establishment of 142 new first-year residency positions, which would accommodate the full complement of medical students who would be graduating once the program is in its 5th year. I'll remind the board, you saw this, this slide in August, but we do have a statutory requirement. The board may not summarily disapprove a program without completing the review required by this section. The statute actually lays out 4 criteria that the program must meet during the review. The statute does not limit the coordinating board to consider only those criteria. The staff review includes several things. It incorporates factors such as workforce demand, student financial assistance, library, and IT resources. We use this to fully inform the board about the resources that are in place to offer the program. Looking at the education code, it lays out what we consider really 3 topics: need, cost, and quality. The last 2 deal with quality. And the 3rd one deals with faculty, which also deals with quality. I won't read those to you, but that's the way we think of them here. So with regard to the first criterion, the program is needed by the state and local community and does not unnecessarily duplicate programs offered by other institutions of higher ed or private or independent institutions. The staff perspective is that the proposed program partially meets this criterion, and here's why. Texas has expanded the medical education across the board. And in 2017, the state actually surpassed Pennsylvania with the 2nd largest entering medical school class size. However, Texas ranked 36th nationally in the ratio of medical students per 100,000 population. So our population has grown so quickly and so rapidly that the opportunity for medical education is, we're not number 1. We're number 36th. Houston is home to 2 mature medical schools. Neither is slated to increase in the class size in the coming years. A&M Health Science Center has a partnership with Methodist Hospital Houston, and it serves now as one of its clinical training sites for some of its medical students. And UTMB Galveston and the site of the recently approved Sam Houston State University DO program are in the region. So, continuing on, there is a need for a diversity in the physician population, as you heard Dr. Spann describe. There's also a need for improved geographic distribution, including getting physicians to practice and have a patient population that's in the inner city and in the rural areas. So it's evident from the information in the proposal and subsequent information, the program would have a model of admitting underrepresented students into the program, and that could lead to students who are likely to have a practice with underrepresented patients. Educating underrepresented medical students may also encourage them to enter primary care. And they also, as Dr. Spann talked about, they have innovative curriculum. They include a flipped classroom model approach and the longitudinal experiences that actually promote primary care. Moving on to the next criterion, this one's about financing. So the proposed program does meet this criterion. U of H, their proposal has a mixed model of funding, which relies on special item funding, formula funding, tuition and fees, reallocation of institutional funds, and donations. They've set their tuition and fees at a level that is comparable to other existing state public medical schools at $22,510 annually. And they received a donation of $3.2 million, which will cover the inaugural class all 4 years as they move through the program. The first staff recommendation is that the U of H will commit to aggressively pursue funds to provide scholarships and/or loan repayment to achieve its goal of having 50% of its students from underrepresented populations. The third criterion, again, this is about faculty and other resources necessary for a successful program. Staff perspective is that the criterion was met. U of H hired 7 core faculty and has committed to hiring 20 additional core faculty. They identified 37 existing faculty that could support the program, and they have 90 master's degree programs, 45 doctoral programs, and 3 professional practice programs. They also have existing space in a building that was opened that will house the medical students for the first 2 years, and they have plans to develop another freestanding building to accommodate the growth of the medical students in the coming years. The second recommendation is that the institution will provide documentation of hiring 20 additional core faculty through the submission of letters of intent, curriculum vitae, and provide a list of courses to be taught prior to August 2020. And the last criterion, the program meets the academic standards. These are the 19 different criteria under this section, and the perspective is that the program does meet this, the proposed program meets this criterion. So additionally, the criterion actually specifies other related and supporting doctoral areas must be available. Again, U of H, as Dr. Spann referred to, has several related and supporting areas in biochemistry, biology, biomedical engineering, clinical psych, counseling psych, school psych, kinesiology, neuroscience, pharmacy, and pharmacology. They also offer special professional degree programs in pharmacy and optometry, and they offer a post-professional master's of legal letters in health law. The institution offers master's level programs in nursing administration, nurse practitioner, and nursing education. Additionally, staff perspective is that they meet the criterion, and they will provide documentation of hiring the additional faculty. Continuing on, U of H has provided clear communication that it would provide financial support for the inaugural class, and it did receive $3.2 million in a donation to cover that cost. And again, this is the same recommendation, recommendation 1. They commit to having scholarships and or loan repayment options to achieve the goal to get more underrepresented populations into medical school. Oops. And as you may recall, House Concurrent Resolution 102 was passed by the 85th Legislature, and it expresses the legislature's requirement that a prioritization of a substantial increase in funding for GME before it considers authorizing the creation and support of additional medical schools. It charges the coordinating board to work with institutions to achieve the 1.1-to-1 ratio goal for the number of medical school graduates to the number of first-year residents. And I'm pleased to say that Texas, while right now we have exceeded that goal for 2017, I'm happy about that, but unfortunately we're asking for an additional $60.675 million in GME expansion money in the agency's LAR, and that would cover just the medical graduates that are coming out of the schools today. Senate Bill 1066, also passed by the 85th Legislature, required that a specific plan regarding the addition of first-year residency positions would be in place if an institution proposed an MD or DO program. The plan must propose an increase in the total number of first-year residency positions in the state sufficient to reasonably accommodate their and other medical schools' projected graduates, and submission of a specific plan was required. The staff perspective is that the institution met this criterion and provided a specific plan. They originally had submitted that they were going to have 103, but now that number has actually increased again. They have the relationship with HCA Gulf Coast to develop new residency programs. Again, Dr. Spann alluded to those in his remarks. The institution included affiliation agreements with GME hospitals, community health centers, and local foundations. And given that the institution proposes to open with a minimum of 30, they're going to enroll 30 students in fall 2020. They would need 30 residency positions by 2024. So this is my final slide, and again, the approval is with the 2 additional recommendations. The institution commits to aggressively pursue funds to provide scholarships and/or loan repayment to achieve its goal of having 50% of its students from underrepresented populations. And recommendation 2, that the institution will provide documentation of hiring 20 additional core faculty through the submission of letters, CVs, and provide a list of courses to be taught. I'm happy to address any questions.
Dr. Peebles?
Thank you. Yeah, just to reiterate, we recommend approval of the medical school with those 2 additional recommendations. And I'll just leave it at that and then be glad to answer any questions as well.
Okay. Commissioner, do you have any comments?
The only comment I have at this point is I would like assurances from Dr. Short and Dr. Spann that, as you know, there have been some discussions going on the past several days about the language regarding your institutional commitment to enrolling students from underrepresented groups and so forth. And I know there's some questions about legal questions about the language, and I appreciate those, but I'd just like to be assured by both of you that your commitment to diversity, your commitment to underserved communities hasn't diminished from what you said in the proposal originally.
It has not. In fact, the University of Houston is the second most, student population, second most diverse of any research university in the country. And we take that standing very seriously. We know who we serve. We know who we want to serve through this program. That has not diminished at all. And all of the things that we do, all of the structure that we're putting in place is to achieve that goal. So we stand on that firm belief and firm mission and moral obligation to do that.
Dr. Spann?
Just to reiterate what our provost has so well articulated, we're seriously committed to recruiting students from underrepresented populations of all backgrounds, not just, quote, underrepresented minorities, but a fully diverse group of students, and to train them to serve those in rural and urban underserved areas, and to serve diverse populations. We do have a concern about the 50%. I think you know that, but I'm not a lawyer, right? I'm a physician, so I personally resonate with the idea of training as many of these young people as we can that come from underrepresented populations. But I think there are some issues around putting a percentage number on it. We're concerned that some might argue that placing a number would be akin to developing a quota. And this perhaps would be problematic. I think we're all aware of the Supreme Court precedents in both the Grutter case of 2002, affirmed in Fisher of 2016, that really preclude having specific quotas around admission of certain populations. So we are committed to diversity. We're the second most diverse campus in the country. I think we'll have a very diverse medical school, but we would respectfully request that the number itself be removed just so that we are compliant with the law of our land.
Follow up with that, Dr. Spann, if I may, before we get any questions, is in your presentation you mentioned the holistic approach of admissions, and I think you just cited one example. How does that differ then from trying to get underrepresented areas?
Well, I think a holistic approach is consistent with trying to recruit and admit students from a broad, diverse background, including geographic place of origin, such as rural or inner city. I hope I'm answering your question.
You have. Thank you. Chairman Stedman, do you have any comments?
No comment. I have a couple of questions, but I defer to the committee,
Okay. Thank you, Dr. Spann. Okay, at this point, we will open up for questions. Mr. Raven.
Thank you, Mr. Chairman. Dr. Spann, thank you for a excellent presentation. I mean, you can see the amount of energy and time and effort that has gone into it, and it's very comprehensive. To go back to the recommendation number one, I mean, I recognize, being a lawyer, I'm kind of sensitive to what you mentioned about the 50%, but at the same time, the University of Houston, being a double alumnus of the University of Houston, is in a unique place, has a unique calling. Can you talk to the committee a little bit about how you plan to develop a relationship with the Third Ward?
Absolutely. We have ongoing efforts to partner with our surrounding community, the Third Ward, in a number of areas. First of all, our School of Education has a significant project of partnership with elementary, middle, and high schools in the Third Ward that are underperforming. And the goal here is to get them up to the state requirements in terms of performance and ultimately to provide better education for those students. In the health area, we have a number of projects, active projects going on, including See to Succeed, which is a project to help students in elementary, middle, and high school who have problems with their visual acuity to have glasses as needed to be able to see and to study and to read. We also have a project ongoing that focuses on prevention and early detection of obesity and intervention to prevent obesity and to treat obesity when it's already in place. And a big focus of our medical school will be to partner with that community, not from a top-down levels where we come in and say, here's what you need to do, but from a real grassroots level, what are your problems, what do you see as your health problems, and how can we work together? On the business front, our business school has an incubator for new businesses to help folks in that community become entrepreneurial and start new businesses, and we've had a number of successes in doing that. And then on the arts front, we have a long track record of working with the community to provide art projects, so at multiple community levels, we're partnering with this community to improve the overall quality of life.
Excellent. You know, it is a sense of great pride for me being a University of Houston alumnus. Ross Lynch used to tell us that at one time there will be a day when people will recognize that the University of Houston is in a unique spot because it's the biggest university in the biggest city in the biggest state in the southern half of the country. And I think that day has come. I think a job well done.
Other questions? Yes, Chairman Stedman.
So we've heard a rumor, perhaps, that, and I think you addressed it in one of your commentary or your summaries, that the Texas Medical Center is interested in having your building housed on medical center property, and I presume, you know, they make a lot of money from that parking, so maybe there's some financial incentives, but you were clear in your intent that you would like the medical school building that you'll build in a couple of years to be on campus. So if you could just address that question.
Thank you, and that's a fair question. It's a difficult one to answer in my position, but I'm going to be totally honest and transparent. Let me just say that my strong recommendation to the chancellor and to a number of our board members has been that because this is going to be a community-based medical school oriented to training primary care physicians, it should be in the community on our campus and not in the world's largest tertiary care medical center. But there are some forces, of course, that would perhaps seduce folks to think about putting it in the medical center. We do have a plot of land there where the pharmacy school has been historically. It got flooded out during Harvey and would have to be totally rebuilt. And there are some people who think we should consider putting a building there for a medical school. I think there is some pressure from the Texas Medical Center. They would really like for us to be in the new TMC3 space. I think we decided that really does not make sense. And I think there's some people that think, well, if we had a big, tall, shiny building in the TMC with U of H, you know, on top, that would be an important branding factor. I think it's fair to say that we're in the process of doing a lot of due diligence, careful analysis of this. the decision will not be made lightly, and I am hopeful and optimistic that at the end of the day, we will build that building on our campus.
Dr. Short.
And I might add, from an academics perspective, because of the enormous amount of programming and faculty already on the campus that want to connect with the medical school, both in research, teaching, shared teaching, the proximity to the medical school is important to really facilitate that. So if it ends up on campus, that will be an additional benefit, I think. To
and that's consistent both with your commitment to the underserved and your neighborhood to have it on campus, as well as what you've said about helping bolster existing programs and vice versa. My second question, and I don't really want to put him on the spot, but I'm very interested in the subject. I'm very impressed that you brought Dr. Nesbitt from HCA. Would it be okay if I ask you just a couple of questions?
It was me, yes, sir.
Okay. Well, my so just in general, and this is more of my for my own edification. I mean, I know training undergraduate medical students is expensive, and GME slots are expensive, and I'm a little fuzzy about the formula funding for GME. And at some point in the your presentation, not presentation, but the supplementary materials, there's that Medicaid thing or Medicare thing that after 5 years you get a reimbursement, all that very complicated stuff. But bottom line is, what is your interest? And I'm very impressed with the University of Houston for bringing representative of your partner to this meeting. I think it shows it's a critical piece of a medical school, and I appreciate your presence. But so from HCA's perspective, what do you guys get out of it?
Yeah, thanks for the opportunity. We're just really thrilled about this partnership. And I've told the Chancellor and Dr. Spann several times it seemed like the stars aligned at the same time. HCA is a very large hospital organization. We have the largest in the country, in fact. We have 180 hospitals. We're actually the largest provider of graduate medical education in the country, believe it or not. It's like the statistic that we're the largest provider of hospital services in Houston now, since we acquired our new facilities in the last 12 months. So very committed to graduate medical education nationally. We struggle, as everyone does, in recruitment of new physicians. So we have a passion and have proven a return on any kind of investment for graduate medical education training with recruitment, not only in primary care, but in some specialty areas as well. So we have inherent business logic and commitment to GME. It is a very complex reimbursement system. I've overseen 3 graduate medical education programs, and I still don't understand it. But there's indirect, direct cost, and all that stuff. We do get payments by the government by providing the service. But there is a loss for, the first few years, but it is a long-term commitment that HCA has. So what's in it for us is just a wonderful academic partner. We do better. We do have some independent graduate medical education programs in the country without academic partners, but it's much better if you do have an academic partner. So it's a great win there for us.
And with respect to the clinical rotations, why is that? Because that's, these young medical students probably don't know much. So what's the interest there?
The baby doctors are a burden the first couple of years. That's no doubt. We have, and I was really pleasantly surprised, and Steve will tell you too, that the reception that our medical staffs have that we've received from them on the commitment for volunteer faculty. There's no payment for many of the faculty that's going to be babysitting, if you will, these baby doctors, and then when they get to be graduate trained, there's a year there or so that they have to get up to speed. Actually, they will provide resources for us in their 3rd and 4th year of their residencies. So there's some benefit to that. But I think it's again a commitment, giving back, training, recruitment for new physicians with this shortage that is just very, very real.
That's interesting. The chairman of the Higher Education Foundation, Neil Adams, is a lawyer, and we're talking about internships, really for undergraduate college students. And he said, well, you know, the legal profession figured that out long ago. In other words, you give clerkships, you spend a summer, they get to know each other, and not only is, I mean, just the recruiting tool, but you see if there's a fit. Anyway, I appreciate answering my questions, and I very much appreciate U of H bringing your corporate partner, a healthcare partner, to the meeting. Thank you.
Okay, thank you. Ms. Acosta has a question.
Actually, it's just a comment. I want to thank you all for all of your years of hard work of putting this together. Especially want to do a shout out to your fearless leader, Chancellor and President Renu Couture, who I know couldn't be here for a very important reason. Actually, we changed the date on her, so that kind of messed it up a little bit. But, you know, I really have to say that since I joined the coordinating board in March of 2016, she has been very open about sharing ideas and asking for ideas. And the most important impact I think that you can make outside of brick and mortar is your community. And I echo my sentiments of my colleague, Ricky Raven, that revitalization and economic development and just changing lives and transforming lives with your entrepreneurship program. I think it speaks volumes to what we have to do in Texas. We have to look outside our beautiful walls and our beautiful windows and try to see how we can reach down and help, generations of lives. So I want to thank you all for those visions and to continue to support, the underserved communities that we have in Texas, especially the underserved students. So thank you again for your presentation.
Any other questions or comments?
One question real quick. On the recommendations regarding percentages, is there a precedent? Or do we, on the board, I'm new to the board, do we normally impose quotas in recommendation with programs, or as far as percentages and stuff?
Rex, go ahead.
Isn't it, my understanding is what they're saying is it's their goal, their percentage. We're just, recommending that they have financial aid for that, whatever their goal is. Is that fair? Didn't the 50% come from you?
It did. Again, that was with a doctor hat and not a lawyer hat on. That was my goal.
So our emphasis, I think the staff's emphasis, is simply for those underserved students, whatever their goal, however they express it, that they're aggressive in getting financial aid so they can recruit those students.
Yeah, and just a quick note on that, I think it's important to point out that it's asked them to aggressively pursue the funds. It doesn't actually set a quota of 50%. It asks them to do the best they can to reach the goal that they had set for themselves.
Any other questions or comments? Okay, I also would like to echo Mr. Raven and Ms. Acosta's comments. I think your proposal was very well prepared, and you did a great job in terms of providing the information to the board. And so I also commend you for all the work and that you guys have put into it, the University of Houston and the system, because I know it takes a lot of work. And I think this is probably since I've been on the board, maybe the fourth proposal for an MD or a DO program, and you guys have done a great job. And again, remind everybody that this is the committee that will be voting on a recommendation to the entire board, which will be brought up in the October board meeting. Okay? Yes, Mr. Anwar.
I'm sorry, I'm not on this committee, but I like to echo my sentiment of what a good job you have done. Thank you.
Thank you, Mr. Anwar. Any other comments or questions? If not, do I have a motion to adopt the staff recommendation?
So moved. Second.
Okay, motion by Mr. Raven, second by Ms. Acosta. All in favor, please signify by saying aye.
Aye.
Any opposition? Hearing none, the motion passes. Thank you. Thank you all for being here. Appreciate it. Thank you, Dr. Short and Dr. Span. Yes. Commissioner?
Yeah, I'll wait till people settle down.
Okay.
I wanted to make a comment, and I wanted to wait until the vote was conducted.
Okay.
I agree with everything that's been said about the high quality of this proposal and the fact that there is a very significant way in which Houston could benefit from the development of this medical school. The question that I had in mind, and I think everybody knows I've raised questions about the medical school. The question I had in mind was, given all the priorities, given all the needs we have in higher education in Texas, should this be one of our highest priorities? When you look at when you look at the resources at small schools, particularly for example, in South Texas and along the border, the resources that they have, you could argue, you could make the case that our greatest need is to help improve undergraduate education, to provide resources to the students to get an education. You saw it earlier how far short Texas stands in terms of providing financial aid to poor students. It's very clear that we have to continue to expand higher education in Texas. But I think we need to do a better job of establishing which issues need the most urgent attention and plan around those. I think it's also clear that as we give institutions authority to create new programs in schools, that we also urge the institutions to be more cost effective. We still have an awful lot of, we have a lot of opportunities, for example, closing down low producing programs. All institutions who are supposed to note those programs in their LAR. My understanding is that quite a few institutions have not, and I urge them to do so. We need to take a look at other issues such as expanding or controlling the expansion of facilities by making fuller use of the facilities we have in place now, doing more teaching and learning on weekends, on evenings, on Fridays, which now is a day when classes are seldom taught. We need to make sure that we need to focus on improving existing programs, perhaps before we consider creating new ones. But if we are going to achieve all the needs or reach all the goals we have for 60 by 30 and beyond, we're going to have to significantly reinvent public higher education. I point out, if you read the financial aid report, that between 2003 and 2017, state support for public higher education has declined 23% on a student FTE basis. And that it's highly likely that we're not going to get back up to the numbers that we had in the early part of this century. We're going to have to find ways to economize, to deliver higher education more thoughtfully and more effectively. We're going to have to get more big institutions to appreciate the dire circumstances of some of our regional institutions and recognize that everyone in higher education has a responsibility to look out for the entire state, not necessarily the parochial or limited interests of given institutions and given systems. So with that, congratulations.
Okay, thank you, Commissioner. We next move on to Agenda Item 5C3, and that is the consideration of adopting the staff recommendation to the committee relating to the request from the University of North Texas Health Science Center for a Doctor of Medicine degree with a major in medicine. I would like to call up to the microphone representatives from North Texas Health Science Center. Welcome. Dr. Michael Williams, President. Dr. Stuart Flynn, Dean of the UNTHC TCU School of Medicine. Welcome. And Greg Anderson, who is the CPA Executive Vice President of Finance and Operations. Welcome, gentlemen. Okay.
Mr. Chairman, members of the board.
You turn on your.
I'm sorry, I'm used to them always being on. So, I'm in my 6th year of service, and I have the honor of being the president of the UNT Health Science Center in Fort Worth.
I want to thank you for your time and your service to Texas and Texans. My background is not from a traditional higher ed background. I come from the private sector, practiced medicine for almost 25 years, and was a hospital CEO for several years, and then was asked and had the opportunity to take this position. After a number of years in the private sector and years of frustration in working with some of my physician colleagues to go in a different direction as it respects to truly putting the patient in the center of what we did and not being as focused on the providers, it was a different kind of passion that I had, and because I did have the passion in my firm belief that healthcare has not always been for the patients, it's been often for the good of the providers. But after years of trying to get physicians to change their ways, and me being one of them, as we all were trained in similar generations, I had the opportunity to come, if you will, at the headwaters and have an opportunity to change the way we train physicians and change the way we train providers. So the premise of my presentation is going to be around that this is a new model of a medical school. It's a new model of an organization. It's a new model of delivery through an innovative curriculum that I think hopefully you'll see has significant merit. So why a new medical school? Well, the common reasons you've heard of before from other presenters, I'm sure, the same numbers that I can give you. We're 41st in the U.S. in physicians per capita. We're 47th in the U.S. in primary care physicians per capita. For many years, we've been one of the top 10 states in terms of population growth. But yet we still face physician aging, physician burnout, and also growth in early retirements for physicians. We really desperately do need to attract and retain more physicians. And I've heard the commissioners say before in testimony that we need to think out of the box about how we approach funding of medical schools, and I would expand that to think out of the box of how we train physicians. But yet the interest in healthcare careers continues to grow, and we see a growth in applications from students. I can give you all those reasons, but that's not the main reason we're here. The main reason we're here is because of what I said earlier. We need to train a different kind of provider that's more adept for the future and is ready to go adapt to the future that is now. Healthcare is being disrupted significantly from the outside, not the inside. We have to have providers that are ready to adapt to that and live in that world. Many of my medical school colleagues of the 170 plus in the U.S., there's still many of them that are training in the post-Flexner report model of 1910, 2 years of basic science and 2 years of clinical training. We see that model, at least in my personal experience, has led to a situation where we find physicians having to work in a more impersonal model, where we're having to move patients through quite quickly. There's not a spirit of teamwork. The care delivery is not always integrated. We see the issues around communication. I know all of us are patients. I don't know how many of you have issues about getting your own lab data from one physician to another. Physicians don't always communicate with each other as peers or with the patients. We see high costs in healthcare from duplication, from errors, from quality issues. Just those three are approaching over a third of our total U.S. healthcare spend, yet we've not addressed those issues. Patient experience has not always been a priority, but yet there's increasing complexity within the system. We have a growing reliance on technology by our providers and less on the patient interaction. I've seen patients who go to the emergency room for issues such as sore throats and get a CT scan of $2,000 or $3,000 with no regard for a physical exam. And I'm speaking very bluntly to you because this is something I'm very passionate about. It's an issue, and it's an issue that we want to change by training a different kind of provider. We've lost empathy and altruism by the model by which we train physicians, in my opinion. Employers are telling us this as well, who hire physicians. They want physicians, and they're trying to remediate physicians after they graduated with things like emotional intelligence and communication skills, leadership skills, ability to work on a team. And that's not their job. That should be our job to train them before they get them. So we think now it's time for a new physician and a new way to train. A provider that's intentionally selected with different kind of methods and parameters, that's trained intentionally with new skills, with high empathy, emotional intelligence, and maintained altruism throughout their career. Well-developed communication skills, leadership on a team, as well as knowing how to follow on a team too, is key. We want students who can be coached and learn how to coach others. We want students that are active listeners. We know the average patient interaction right now, the patient is interrupted in the middle of telling their story within 17 seconds of the interaction. Yet we're all taught as physicians, if you listen to the patient, they'll tell you the diagnosis. We have to change what's going on there, and I think we can change it by training a different kind of physician. We want physicians who are lifelong learners. We know that the average physician now stops learning 5 years after residency training. Those are significant data points that we have to address by how we train these physicians for the future. We have to have physicians who are comfortable taking care of patients in multiple settings that are the highest value for the patient, not necessarily the provider. And what I mean is comfortable taking care of patients in the home, in a mobile setting, through telemedicine, comfortable in the technology that's around us now with wearables, iPhones that can do electrocardiograms, echoes, those kinds of models. It has to be where is the highest value. So how did we address this problem? We addressed it by starting off with a blank canvas. Because as many of you know, from as many schools as you hear from, it's almost impossible to go into an existing, well-established school and completely transform a curriculum. So we started with a blank slate, a new curriculum, hired Dr. Stuart Flynn, who had experience in building an innovative model, and we're very proud to have him as our team leader. We approached a new admissions process that's going to focus on the right kind of individuals that have emotional intelligence, that have the proclivity to work on a team, that have demonstrated leadership. This new model, from an organizational perspective, is also unique. It's a public-private partnership. Public-private partnership medical school, and this is the first one of its kind in Texas, one of the first of the few in the U.S. There are others that have done this with a hospital system as a partner, but we're unique in the sense that we're the only one we're aware of. There may be one or two others where two universities came to create a brand new school in a partnership model. So this also led to close working with accrediting bodies because it's an innovative move, an innovative model of which accrediting bodies are not always adept at understanding. We've had great relationships with the LCME through the process from early on to get their understanding and as best we could support for what we were trying to do. This has led to a new faculty model. The school has no tenure or tenure track. It's a dependency on community physicians as well as a few full-time physicians. We depend heavily on a process which I think is the way we were meant to be trained around mentoring and coaching and development of what we call the empathetic scholar. It's made up of 9 selective attributes that form the scholar. We want to build synergies with our provider partners and the provider disciplines, so that's why we wanted the school to be on the Health Science Center campus. When we got our pharmacy school awarded to us by the legislature a few sessions back, one of the key things we told the legislature was this will be the only pharmacy school in the state of Texas that's on a Health Science Center campus. Why is that important? It's important because where care is going, it's a team-based model of care. The days are over where I'm the sole provider, physician in my office with my staff, and I'm the one who's the keeper of all the knowledge around healthcare. The knowledge that's needed is right here. But we need to be able to help patients get to the knowledge and how to navigate through that. So we wanted them on a Health Science Center campus where they're working with PA students and pharmacy students and PT students and researchers so that they get a sense of what the team looks like as we move into the team environment of care delivery in healthcare, because that is where we're headed. As a former ICU physician who ran an ICU every morning, I rounded years ago with a team. I rounded with a pharmacist, a nutritionist, a social worker, a nurse, a respiratory therapist, because I learned from them and the perspectives they brought. It wasn't about me being the sole knowledge bearer and you do what I tell you to do. We're all better on a team where we respect the value that these other providers bring. Therefore, it's important for them to be trained on the Health Science Center campus, we feel like, and be part of that bigger team. So we're huge believers in teamwork. And we think there's rich synergies that come out of that no one's really tapped into. Why Fort Worth? Fort Worth's the 15th largest city with very minimal medical education penetration. We've had a long history of the osteopathic school there, and I'll explain that more in a minute. The hospital systems, however, have not fully been penetrated with medical education. We think there's real opportunity there. There's been strong community support because there's strong community support in Fort Worth for both TCU and the Health Science Center. They're both seen as strong assets and deliverers of education. The DFW area is ranked as the number 8 out of 10, one of the top philanthropic areas in the U.S., and we've seen that come to fruition as this school got started. It's a city with a long history of growth through partnership and collaboration, of which we want to embody as two key universities in the area. There's six large successful health systems there, as well as the largest physician-only accountable care organization in the entire state of Texas is there as well. Why TCU? TCU has a great history as a liberal arts university. They've got healthcare experience with their nursing programs. They've got strong business schools, engineering schools, liberal arts, and communication studies, all of which we think can add value to the medical school. When we have physicians who learn some engineering training around problem solving, when they understand some business skills, when they understand leadership, when they get the influences of the liberal arts experience as well as communication, we think we'll have a better physician. There's strong financial foundation at TCU, and they've been a great partner. Why UNT Health Science Center? UNT Health Science Center has almost a 50-year history of very successful medical education delivery. After listening to the previous testimony, I will tell you that I'm very proud of what we've done at the Texas College of Osteopathic Medicine. We, for over 10 years, have delivered more primary care in the state of Texas than any other medical school here. We average, and have averaged since the inception of the school in 1974, more than 60% of that class going into primary care. It's a culture that you develop. There's a culture around primary care. There's a culture around rural healthcare delivery, and that's something we're very proud of our long success with. So we have 50 years of substantial history, recently leading to TCOM actually delivering at 99% level in the U.S. LME, far beyond their other peers in the state of Texas, as well as a 10-year window now on accreditation, which is a huge thing to try to achieve. And they've been given that by their osteopathic accrediting body. So where are we now? Well, now after 3 years of when the idea first came forward, we've opened a brand new state-of-the-art facility. Actually, the official opening will be October the 18th, that will house the new MD school. We solidified our partnership with TCU over the last 3 years with significant key agreements. We've raised almost $80 million through philanthropy that goes into an endowment. We've completed, which I'll ask Dean Flynn to speak more of in a minute, we've completed our LCME site visit, and as you know, we completed the coordinating board site visit. We've hired many faculty and staff, and we continue to engage the Fort Worth community, which has continued to show significant excitement that was exemplified through the LCME visit when they actually interviewed several community leaders. We recently, in the last legislative session, passed House Bill 1913, which gave us the approval to deliver the MD degree at the Health Science Center. That bill passed with a lot of legislative strength in the House with 145 to 0 and the Senate 30 to 1, and there's clear legislative intent to deliver on the MD school and the MD degree established in the legislature. We've now finished signing undergraduate medical education training, UME training agreements with 6 major health systems in the Fort Worth, DFW area. We've also signed an agreement with Catalyst, which is the largest physician ACO, or accountable care organization in Texas, has over 600 physicians and 150 sites in the DFW Metroplex. So I don't even know the total of training sites we have available to us now, but I know it's over 40 hospitals and clinics, and growing with the further agreements. The agreements we've established with the Texas Health Resources is a DFW-wide agreement. The agreement we have with HCA, or Hospital Corporation of America, is similar to what you heard from Houston. It is a DFW-wide agreement for our UME training. I'm extremely proud of the work we've done on GME. Since my 6 years of being in this position, I've heard repeatedly and agreed fervently with the need for more GME. We've approached this problem from three different directions, 3 different pathways. First of all, we use the expansion grants to generate 20 new spots in existing programs. 20 doesn't sound like much, but at $150,000 apiece, they're significant per year. We took 452 formally approved osteopathic residency programs and put them through the filters and the approval process for the ACGME. 452 of those have now converted to ACGME residency programs and will now be available in the national match. So that's 472 total. And then we've signed an agreement with both Baylor Scott & White and the Hospital Corporation of America over the next 4 to 6 years to develop 650 new slots. So by new slots, conversion of existing osteopathic slots, and expansion slots, we're now well over 1,100 slots that will be available in the match. So I'm very proud of what we've done on GME. Related to financial aid and support, we want to strongly stand up and be supportive of our students, and we understand the significance of the debt issue. And related to that issue, just in our early fundraising, we've already put away almost $2 million in endowment dollars for scholarships. Our partner TCU is about to undergo a $752 billion campaign, of which a significant amount of that focus will be on scholarships for students. We have a naming gift of $50 million in the final stages, of which we think there's opportunities to set aside some of that for scholarships. We think by year 4 of this medical school's student population will be well over 2.6 million put aside, and even more to offset some of the costs. This sets up to a 15% level, which we base that on a historic experience we've had at TCOM of a 10% level. But regardless of what the number is, the percent is, we're heavily committed to reducing the student debt load. In summary, I'm going to say it this way for Mr. Chairman and the committee members. The Health Science Center has a vision of being one university, one campus, delivering on one key direction. We have a clear purpose of transforming lives. We strongly believe in a set of aligned core values, which we live by every day. We believe heavily in extraordinary teamwork, partnership, and collaboration. That's why this school is modeled in the way that it is. And I'm going to close with these last 2 comments that came from 2 of the site visitors that came with the coordinating board staff team to visit our school. Dr. O'Donnell is Professor Emeritus of Medicine and Psychiatry at Dartmouth. First, his quote was, you guys had the guts to do what we all needs to be done, but none of us have had the courage to do it. He's referring to how we train physicians. You're going to be the leader in medical education, and when people figure out what you've done, they're going to beat your door down to figure out how to do it. I don't say that out of arrogance. I say it out of respect for someone who's lived their entire life in medical education, and he's able to see the difference in what we're trying to create. And secondly, Dr. Frederick Hafferty, who's Professor of Medical Education and Head of Professionalism at the Mayo Clinic. His comment was, I'm at the Mayo Clinic every day, and I must tell you, I've never been anywhere where all I heard from people was how strong you believe in and live by and to make decisions on your values, your core values. And I wanted to tell you to keep it up. It's obvious that you're here for the right reason, and the values are woven in your fabric of who you are. So with that, Mr. Chairman, I'd like to turn it over to Dr. Flynn for some comments. I appreciate your patience with
Thank you, Dr. Williams. Yes, Dr. Flynn.
So I'd also like to thank you for the opportunity to speak. President Williams is a difficult act to follow. I'm going to try not to repeat him, but I also will say with absolute candor, the reason I packed my family up in a moving van, well, we came in a van, the furniture came in a moving van, was because of the 2 universities I have a chance to start this school with, but also President Williams. And I always feel like I'm hearing a pregame talk when I listen to him. So let me just highlight what he said. You already sat through an entire curriculum presentation with the last school. I don't need to do that. You have a pretty strong understanding of medical curriculum from that. I will start by saying we are going to train the physician that you want. And that sounds hyperbolic, but this is the opportunity we have. When President Williams said we had a clean slate, that is exactly why I'm here. And I will tell you the background of that. I spent 20 years at Yale University running their medical school curriculum for a large part of it and running their GME for a large part of it. And just to highlight, and I love that university, so I don't want this taken the wrong way, but I was given the mandate by a national foundation that gave us a grant that we needed to teach geriatrics in our medical school curriculum. And the audit showed We really didn't have geriatrics in our curriculum. And when I tried to bring it into the curriculum as the leader, there was pushback. And the pushback was they were comfortable doing what they were doing, and there was no time for anything new. So I highlight that not, and I hope Yale isn't watching this on the internet, but that's just a reflection of where medical education is. You may have heard President Williams mention 1910 in the Flexner report. If you take a peek at that report, I will tell you, virtually every medical school in this country right now is training to the 1910 Flexnerian model. It has to change. So we want to train empathetic scholars. And now I will just tell you very quickly how we break that down. Again, we have a clean slate. So our students will see patients their first week at medical school. That's no longer novel. But they will follow those patients, that little handful, for 4 years. But when they actually do their clinical training, it will be out 80% in the ambulatory setting, and they will end up with a small panel of patients that are theirs. And that means those patients no longer are a disease in room 7 in the hospital or an organ in room 10 in the hospital. They'll be a patient with a life, a story, a family, adversity, success. And that is what drives empathy. This has been nicely studied in medical education. Medical students enter medical school. They are the most idealistic young people. You just should come someday and just spend a day on an admissions visit. They just want to cure and they want to help. By the time they graduate from medical school, that empathy has tanked. And it's not because we're mean. They work hard, but they know that. It's because the medical education system and the medical education system is you have to get them in and out in a matter of hours. They do not get to know their patients. So that, and this has been nicely shown, this model is done in 32 countries, Canada, Australia, and they've done studies looking at the empathy of their students, and it stays right where they started. And a curious offset of that is their faculty feel more fulfilled also, because they get to mentor an individual one-on-one and really play a significant role in that individual's career. Second part of our curriculum, we have a mandatory 4-year research thesis. They find no humor when I tell them they're getting more money for their tuition. That's not why we do it. We do it because it teaches them lifelong learning. So now you've seen the empathy scholar. So when they read literature in their discipline, they will have done at least once in their career exactly what those authors have done. So that sets them on the course for lifelong learning. And there are many benefits to this, not the least of which they get better residency programs. But they don't believe that, and they also don't believe the lifelong learning. But I know that because the institutions I've been at have done this before. The last thing I would say about our curriculum is, and in this week of all moments in time, there's a perspective in the New England Journal of Medicine, and it's titled The Mental Health of Medical Students. And what it is in a nutshell is exactly what we know is happening. These young folks are burning out, they are stressed, and the end result is suicide. And so we have to pick up our game. And now there's not a medical school in the country that isn't aware of this and isn't doing something about it. What we're doing about it is we are taking 10 students and aligning them with 3 what we refer to as physician development coaches. Those coaches will advise them career-wise. They will watch their progress. They have no assessment role, so there's no conflict of interest. This is a safe zone for our students. But critically, we will recognize a student who's getting into trouble from depression, from a variety of factors. So I just wanted that to come into the equation. The last comment I will make, and it's in reference to the last presentation, I've spent my whole career at medical schools. the function of a medical school is not just how many graduates it puts out every year. So I will say in Fort Worth, I'm very lucky. The new superintendent of the Fort Worth ISD was a colleague of mine in Phoenix. The new chancellor at the Tarrant County Community College was a very close colleague of mine in Phoenix. So this medical school and both universities work very closely with the Fort Worth ISD, very closely with the Tarrant County Community College, and it's not with the intent to see if we can get some of their students to become medical students. That'll be a beautiful outcome. It's much different than that. It's to understand the value of education and to understand that there are jobs in healthcare. The physicians are just the tip of that pyramid. There are phenomenal opportunities for these young people. And I will close by just telling you the LCME site visit. They have sent us their recommendation. I've been through now probably 12 of these. This is the only one I sat through. I'm proud of this, and I'm bragging, but this is what a team does, and this is what 2 universities do. They had 0 citations for our visit. I've never, in all the medical schools I've been at, I've never sat through one of those. So they, and they've been very guiding in this. And they're watching this curriculum. They're excited about it. So at the end of the story, we hope to change the paradigm of how medical education is done nationally, and not just at the medical school level. If we don't do it in graduate medical education, I think we have not succeeded even remotely close to what we should do in this regard. So thank you.
Thank you, Dr. Flynn. I like your curriculum. My brother graduated from Yale. So, I won't tell him, though.
Yeah, no, don't tell him that.
Okay. Mr. Anderson.
I'm here for questions, if there are any.
Okay. Then we'll move on to Dr. Silverman with the staff.
Thank you again. All right, I'm going to move swiftly through this because I recognize I stand between you and lunch. So, oh, thank you. I think I know how to do that by now. So I'm going to give you the staff perspective. Again, the staff recommendation is approval with 2 additional recommendations. It's clear from the proposal that it would prepare physicians for the region. The budget is different. It would be a mix of tuition and fees, reallocation of institutional funds and donations. The institutions have strong supporting academic programs, existing faculty, and administrative infrastructure necessary to have a high-quality program. And they have provided a specific plan regarding how they would satisfy the GME requirements. I'm not going to go through this again because you've already seen it, and you've seen that one too. This is just, again, the criteria that we review degree proposals. As for the first criterion, again, you've seen these first 2 bullet points. Texas surpassed Pennsylvania as the 2nd largest entering medical school class size as a state. However, we're 36th nationally in the ratio of medical students to 100,000 population. Fort Worth is home to, as Dr. Williams mentioned, Texas College of Osteopathic Medicine is housed at the University of North Texas Health Science Center. And Dallas is home to one mature medical school, that's UT Southwestern in Dallas. And also Texas A&M University Health Science Center has a partnership with Baylor University Medical Center Dallas, and it serves as one of its training sites for its medical students. So, Texas does need more physicians. We need them in specific regions, including inner city and rural areas. This particular proposal has demonstrated that it has strong community support, and this is evidenced through its relationship with TCU. It would combine the strengths of 2 existing programs, and it would implement some educational elements that are innovative and sort of on the cutting edge, similar to what you just heard about in the last presentation, including the flipped classroom, longitudinal experience, and unique to this proposal is that research requirement. Again, you've heard a lot about the empathetic scholar already. I won't go back into that. On this one, I will say that the model depends on a high-cost tuition. So the institution would rely on some state funding through the higher ed fund, TCU's financial support, and it does have a high cost at $60,000 a year for students. So it's a high-cost tuition and fee model. However, they have raised a lot of money, and they received a donation of $3.2 million, which would cover the inaugural class for its first year. The institution has committed to a goal of 15% of all covering all 15% of all students' tuition and fees, and they would not seek formula funding for the proposed MD program. The two recommendations are that the institutions would commit to providing financial support to cover 50% of tuition and fees for students with demonstrated financial need. And the second recommendation is they will not seek formula funding for the proposed program. Moving on to criterion 3, as you heard previously, TCOM has been around since 1974. The institution actually has 32 core faculty and 80 support faculty in place for the proposed program. They offer doctoral degrees in several health-related areas, including pharmacy, public health, and physical therapy. They have expertise hiring high-quality faculty, and they have space that will house the MD students. They have fulfilled the criterion 4, and the staff perspective is that they meet this criterion. Again, they have related and supporting areas in biomedical sciences and public health. They offer special professional degrees, and they offer master's degrees in biomedical science, biostats, epidemiology, and the others. So again, they have met this criterion. Again, the proposal provides clear communication that the institutions would provide financial support for the inaugural class, and they received $3.2 million to cover that. Again, that's the same recommendation that they would cover 50% of tuition and fees for students with demonstrated financial need. I'm not going to go over this because you all know about HCR 102 because I just talked about it, and this one as well. This is the idea. The proposal does offer a specific plan. So a minimum of 60 newly established first-year residency positions would need to be in place by 2023. The proposal included signed affiliation agreements, and the proposal includes development by 2023 of 130 to 200 first-year residency positions in the region. They have signed affiliation agreements with 17 hospitals and ambulatory practices in the area. Those are, again, the summary of the recommendations. I'll conclude my remarks.
Thank you, Dr. Silverman. Dr. Peebles? Commissioner, any comments? Chairman Stedman? Okay, we'll get to the questions, and I think we are ready for the questions. Would you like to start that?
Okay, so I know a couple of physicians that have a really, sort of strong reputation. And there is this, and I'm just curious. I mean, I'm not a physician, really don't know what's all about, but there's this kind of sense, and I don't know if empathetic scholar is the kind of a touchy-feely thing, but there is this sense that the new sort of wave of medical school training gets away from the boot camp environment, the intensity that's required to produce great specialist and cutting edge type positions. So I don't know anything about it, but if you could just comment about that kind of perspective.
I'd be happy to comment from the private sector side, and if Dr. Flynn wants to comment from the education side, that'd be great. So you've hit upon one of my passions, which is patient safety. Patient safety and preventable harm in care settings is at an amazing epidemic level, to where we are seeing, with the complexity of healthcare continuing to increase and physicians practicing the way they've always been taught, there is a sense that working 90 to 120 hours a week turns you out a better physician. I can speak as have someone who not only went to TCOM, did my residency at UT Southwestern in Parkland and a fellowship at the Texas Heart Institute in Houston. I did those 100 to 110 hours a week. And I'm of the firm belief that we made mistakes. You make mistakes because you're tired. You make mistakes because there's a lot coming around you, and the environment now is even more complex. And the technology now enters in that we didn't have at that time, back in the 80s. So I understand what those physicians are saying, and the old premise is, you know, everybody needs to kind of do it the way we did it. But I will tell you that right now, today, somewhere between 250 and 400,000 lives a year are lost in U.S. health system locations of care because of patient safety and preventable, underline the word, preventable harm issues, much of which are tied to just mistakes that are made because of fatigue, of issues with complexity around the equipment, of not understanding maybe the technologies, of just, you know, healthcare is a very complex environment, and it's going faster and faster and faster. So I don't think it's a single multiple factor that trains the best physician. I think it's a collection of things. And yes, I can understand the critique that maybe this is touchy-feely, but you know, I'm going to demonstrate something for you for just a second. If you'll just excuse my, again, I'm not that polished of a guy, okay? This is not the physician relationship that I want to have. I don't want to be talking to somebody's back the whole time I go in. I want somebody to put a stethoscope on me. I want somebody to examine me. I want somebody to talk to me and listen to my story. And in many environments, that's not going on today. So I really appreciate the question and respect the question and respect the direction from which it comes. And I understand that because I lived it. But I really think that we've got to call the question and say that the way we're doing it is causing issues. And I think we change that not by going out and doing a bunch of courses for existing physicians, but we go by how we train physicians coming out. Hope that answers your question. Probably a lot more than you wanted to know.
No, absolutely. I just had no perspective. I'm just cutting my teeth on all of this stuff. But it makes perfect sense, and you lived it.
Well, if you know, my career was in anesthesiology and then ICU, so I did both OR and ICU. And I'll tell you that because fatigue plays a key role in that environment where critical decision making often is made at key points along the pathway of taking care of a patient. For example, in the OR, we used to joke about it being hours and hours of boredom with minutes of sheer terror. And those are all different ends of the spectrum when we're waking up a patient or putting someone to sleep. It's kind of like landing a plane. But if you're fatigued and you're not able to make the right decisions, lives are hurt. But those are not often ever discovered until later on when there's a significant problem. So I don't think the workload has anything to do with training a really good physician.
Okay. Dr. Flynn, were you going to mention something or not?
No, I'm fine with President Williams' answer. I could add more, but then I'm between you and lunch.
Next question is Mr. Raven.
Thank you, Mr. Chairman. My question is not nearly as profound as Chairman Stedman. Is your model like the TV show, the new TV show called New Amsterdam? Isn't that their approach?
We're too busy to watch TV.
So you better take it. I go to bed at 9, Mr. Raven. I don't even know when that show comes on.
Fair enough.
I have a question. Your DO program has been outstanding over the years, and you mentioned that. So are there any plans to conglomerate, do away with it, or have you even thought about that?
Oh no, I'm sorry to bore you with my background. But
I know you're both a DO and an MD.
But
I've studied your file.
As a DO, when I did my residency, I was the first DO to do a residency in anesthesia at Parkland at UT Southwestern.
Right.
I was one of the very first DOs to go to the Texas Heart Institute. I was not treated differently or badly. I wasn't prejudiced against. I know there's some political prejudices that have existed in between the two organizations and philosophies of care. But at the end of the day, that's really what it's about. It's about the philosophy of care. And so just like a PA or a PT or a pharmacist or an MD or a DO, we all come with perspectives that I think need to be valued. And while we are not aware of anybody in the nation that's had success, not even Michigan State, in having a DO and an MD school next to each other, and then Michigan State's is not even on the same campus, we think we can do that because we think it comes down to putting the patient in the center. I won't tell you who I talked to, but it was a state leader in healthcare. And when I brought the idea of a team-based model of care that has a DO, an MD, a PA, a PT, a pharmacist, where the physicians no longer control medicines, but the pharmacists do because they have all the knowledge of those kinds of ideas. The comment back to me was, we're okay with team-based medicine as long as the physician is the captain of the team. And my comment back to him was, how about if the patient's the captain? And the rest of us are there to circle around the patient. Mm-hmm. And so DOMD to me doesn't matter as much as it's honoring the philosophies. Mm-hmm. And what we've already seen by the MD school coming online mm-hmm. is, as I told you, we now have 650 new GME slots that are going to be for Texas graduating physicians. Many of those will be these DO students. They're mm-hmm. going to benefit from that. Mm-hmm. We now have, the report said 17, actually it's almost up to 40 now, training mm-hmm. sites mm-hmm. of where the DO students now, when I went to TCOM years ago, I had to drive all over the state of Texas and part of the U.S. to get trained mm-hmm. because at that time we didn't have training relationships with local hospitals. Now our students won't have to drive anywhere. They'll be able to train right there in Fort Worth. Those are huge benefits that TCOM has gotten because the MD school has coming online. So I think there's close working relationships between Dean Flynn and our interim dean of TCOM, Dean Filippetto. So we're very proud of the relationship between the two, and there is absolutely zero plans to do anything but as appropriately over time and probably beyond my time, grow and sustain TCOM.
Okay, so you'll have both the DO school and the MD school.
Exactly.
Okay, and nothing on the actual TCU campus?
TCU campus facilities, and I'll let you speak to that. I mean, there's going to be some shared things over there.
So during the preclinical curriculum, it's a significant percentage of the training also goes on in the TCU campus. And then once we go clinical, we're not on either campus at that point for the most part.
Okay, so my follow-up question is, what other programs are you thinking about? I mean, you've described, are there any other things on your radar right now in terms of health science professions?
We'll see dental, optometry. No, seriously, Chairman, I don't know at this point. Nothing right now. We're not coming forward with anything. This is where our focus is. We really want to influence the existing curriculums that we have now, and we're already seeing that start to happen. While I said we couldn't transform a curriculum into a brand new one, what we are already seeing is TCOM has implemented some patient safety training. There's some other courses that the way we're going to look at students, interview students. I mean, Dean Flynn can talk about that. He brought the innovations there. TCOM is adapting to some of those now as well, and I think our other schools will as well.
And along with Chairman Stedman's question and the question I asked earlier to the other group is the admissions of a holistic approach in terms of what is your admissions philosophy?
So we were, in my previous medical school that we also started from almost the ground, we were the third medical school in the country to be AAMC validated for holistic admissions. Their comment, which is absolutely true, is if you think just by holistic you're going to diversify your class or your numbers might go down, you may want to think again, because that's not a given outcome. So what the holistic is trying to avoid, just very succinctly, avoid looking at grade point only. We know where you can succeed in medical school. You don't need a 3.9. When you look at your entrance exam, we know statistically where you're not at risk to take standardized exams. That's really what that exam is telling me. So quit keeping it up in the strata, because those numbers, then you can brag about them when you show your class. We de-identify name. We de-identify where you went to school. Because once you get invited to our campus, we don't want those biases. When you get invited for an interview, we don't want those biases. I don't want to know that you went to Stanford and you went to UT Arlington. I'd rather evaluate you for who you are, so to speak, but not to put you at risk in that regard. So we will absolutely be a holistic, but that doesn't guarantee the diversity side of it. It just levels the playing field from the elitism of the top 25 to 40 universities in the country. The other part of it is then go out and form alliances. I think UT Arlington is an unbelievable university. I'm ecstatic that it's in our backyard. We're going to get, and we can diversify our class from there. Set up programs in rural Texas, because we know if they don't come from rural Texas, but they say that's where they're going to go practice, we know that often isn't the case. Or if they have to put in 2 years to fulfill an obligation, they'll put in 2 years, and 2 years and 1 day, they're gone, and that's very disruptive to those communities. So we now will look into programs where we can, and underserved in Fort Worth, which is actually a huge, huge community. But we are absolutely holistic in our admissions process.
All right, thank you, Dr. Flynn. Other questions, Commissioner? Commissioner? Okay. Oh, okay, Ms. Augusta, okay. We'll get to everybody.
So I just had a couple of comments. I want to commend you on the 40 hospitals that you have in the area that created the partnerships. I think that's really phenomenal that you've been able to do. And I also made some notes that I wanted to share with you. I think it's amazing that your team has developed a large number of these residency slots, the GME in the DFW area. I think that's a lot to be said considering what all is going on there. And then the other thing I would say is I do believe that your unique curriculum of how you're training and how you're going to cross-train so many of your students in so many different aspects of the medical fields, I think is very unique because it provides a lot of different opportunities for growth. I don't know all the details, but I read a little bit about your flipped classrooms and your ambulatory care, and so I know enough to say I think it sounds really great that you're doing that. And then the last thing I would say is I commend you on the public-private partnership initiative, and that this is an opportunity that both TCU and UNT decided that would work for them. And a lot of P3s lately, primarily, from Chancellor Sharp and his team over at A&M, and they've been extremely. I want to again commend you. And then Chancellor Rowe, I think, is back there. Would you like to say anything, or thank you for being here?
Just that they've got a great show, and I'm glad everybody's getting to hear it.
Okay, Mr. Wilson.
Your description of the empathetic scholar is profound, and I would encourage, and I'm sure you're already doing it in other schools, to have that approach with all your students and programs, because really mentoring these students and advising them early on and following them through this school system, whether it's medical or other, is, I think, the future and the hope for us to achieve our goal here of 60 by 30 Texas and keeping up with them. How does the empathetic scholar, how does that differ, educate me on, versus your DO approach? Because is that not a similar
I think it goes
to students?
Mr. Wilson, I think it goes to two points. One is, first of all, it was mentioned in some of the documents that the staff and us went back and forth on. That is, if you're going to have empathetic scholar students, you have to have empathetic scholar-minded faculty as well. So it's also a part of training faculty and selecting faculty very carefully. But the osteopathic school has had some of that flavor, but not nearly to the extreme where we are going now. We are actually implementing, for example, you may have seen in some of the documents, Dr. Flynn's team brought some actual ways that you would test for empathy and some profiles around emotional intelligence and other things. We've implemented emotional intelligence, a programmatic pilot with the first and second year TCOM students now that are currently in those classes, as well as the physician assistant school, I believe it is, physical therapy school. And so we're going to run that pilot now over the next 2 years. In the meantime, though, we've implemented screening for some of our dean candidates and other faculty around emotional intelligence and some of the attributes, those 9 attributes that lead up to what an empathetic scholar is. So TCOM has some of it, some of our other schools have some of it, but we're moving everyone to the direction of this complete embodiment of what the Dean Flynn's team has brought forward.
So I echo what was said earlier, that I think it's important that your existing DO program, which is great, not suffer in any way because of the addition of the medical school. So what do you have, you know, if I'm a student medically inclined and I want to get a doctor's degree, how do I, and I come and I'm in North Texas, how do I decide which program to go into?
We're going to tell you, if you really want to be a physician, apply to all 12+ schools in Texas. And TCOM's one of them. And so if you specifically just want to come to Fort Worth for some reason, then you really need to apply to both schools and see where you get accepted.
But how do I decide between the two? If I'm accepted, how do you keep DO candidates long-term from shifting and saying, well, I'll go with the MD program?
Well, it'd basically be requiring them to start all over through the process. And there's a significant barrier of entry, if you will, to cross over. So you either have to understand from two perspectives. Either one, I just want to be a physician, and I don't really care what degree it is. The philosophies are close enough that I just want to be a physician, so I'm going to apply to all the schools. Or if you truly want to be just an osteopathic physician or just an allopathic physician, those students usually separate themselves out on their own. Either they've had family members or legacy influence that got them to go that direction.
And when someone graduates, do they get a degree from University of North Texas or TCU, or how does that partnership work?
Well, that's one of the reasons we're here today, is we've moved far along with the LCME, as you know, and because we had not received, because of the timing, I think it was important because of the innovative part of our model. It was important both for the coordinating board as well as others, even us, that the LCME buy off on it first. And so the LCME, that's why we went further with the LCME first. But in order to do that, TCU had to take the lead on that because we don't have the approval yet. So once, hopefully today, we get approval from you all and can move forward to the October 25th board meeting and then pursue SACS accreditation with the substantive change issue, then it would be a dual name degree.
But initially it's TCU. And
right now it's TCU until
but ultimately it'd be a dual name degree.
Right, and TCU right now is in the stages with SACS for the substantive notification, substantive change of notification.
Because I think us here representing the public side of the equation, I think it'd be important to have, your school named in that degree, long term going forward.
That's absolutely the endeavor we started off with, and we in all fairness, and it's something we all know and we talk about openly between the two partners. We took this idea to them as an innovative partnership, community-based, to really make it a community kind of school for Fort Worth, and so they understand and support the importance of both of us being right there together. So we each have our different pathways to go down.
Great, thank you,
Commissioner.
Yes, I have a very simple question. My question is, we didn't give you a chance to respond to the recommendations that Stacy talked about, increasing your commitment to financial support, financial aid, and number two, agreeing, as you've said in your proposal, that you won't seek formula funding.
We absolutely will not seek formula funding. We told the legislature that both in the Senate Bill 1913 as well as just recently in testimony last week to the LBB again. So that's absolutely no question. In terms of the recommendation of financial support, I'm proud of what we've done at UNT Health Science Center and how we've helped students manage their debt loads compared to other national schools. I think TCU has a very strong history also of financial aid and commitment to some financial and student support, and that's where we're going to continue that strong commitment. In terms of a specific percentage number, I'm not ready to commit to that. Except to tell you as I told you, we have 4 or 5 different initiatives going right now to increase scholarship load and endowment amounts. So we think we'll be at a significant number. I just don't know what that one will be. We absolutely commit to I think, where I see the spirit of this is trying to go.
Okay. Any other final comments? Ms. Costa?
Just to dovetail on Commissioner Paredes's question, I had one comment to make. Will there be any adverse effect on the undergraduate tuition costs in the next, 4 or 5 years as it pertains to you growing this amazing initiative?
In terms of growing the student tuition
in other
load?
Words, are you going to increase tuition costs for undergrads?
Talk to that. There's no immediate plans to increase the tuition.
For undergrad, yes.
Yeah.
Mm-hmm.
Well, that would be probably your Board of Regents that would decide that, right?
When you say undergrad, I assume you meant, maybe I shouldn't have assumed, I assumed you meant the medical school
No,
students.
I just meant regular
Well,
undergraduate.
Oh, we don't have any current undergraduates on our campus of any kind. And
Yeah, okay, then I was just asking as it pertains to UNT.
Well, that would be their Board
no,
of Regents
no,
that would decide
completely
that.
separate.
I understand that. I was just,
Yeah, I now understand your question. I'm sorry.
okay, yeah.
It's completely
I was
separate.
asking for a certain population that doesn't apply to you.
No,
so.
yeah. I mean, I am proud of the fact that over the last 6 years that I've been there, we've not asked for a single tuition increase at
Well, there
the
you go.
Hillside
That's a
Center.
great answer.
So, and we're trying to maintain that because we do firmly believe in the issue around student debt.
Thank you. Thank you.
Okay, if there are no further questions, I also would like to say very well prepared and a great proposal, so congratulations on that as well. At this time, do I have a motion to adopt the staff recommendation? Motion by Mr. Wilson, second by Mr. Raven. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. Thank you all very much for being here.
Thank you all again for your time.
Thank
Appreciate
you.
it.
Okay, we're moving on to Agenda Item 5D, consideration of adopting the staff recommendation to the committee relating to the Aerospace and Aviation Report. Per Senate Bill 458, 84th Texas Legislature, regular session. Members, you have a copy of this report here with your materials. Rex?
So the coordinating board is charged with working with the Texas Economic Development and Tourism Office, which is a part of the Office of the Governor, to produce a report about research activities related to aerospace and aviation technology. And what you have in front of you is that report. And I would just point out a couple of things about it. One is that this was originally conceived of to help support spaceport industry in the state of Texas and to try to sort of move that along and help it in its growth. And in the 3 years of 15, 16, and 17, there was approximately $33 million in expenditures on research in aviation and aerospace technology. That involved 12 institutions. And in 2017, there were total awards of approximately $176 million in the state of Texas related to aviation and aerospace technology.
Okay. Any questions or discussion? Do I have a motion to adopt the staff recommendation? Okay. Motion by Ms. Acosta, second by Mr. Raven. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. Agenda item 5E is consideration of adopting the staff recommendation to the committee relating to the block scheduled workforce programs at public junior colleges report. Per House Bill 1583, 84th Texas Legislature, regular session. Members, you have a copy of this report with your materials. Rex?
So in the 84th legislative session, two-year institutions in Texas were required to block schedule at least 5 programs in the areas of career and technical education or health sciences. And block scheduling, as you can see from the slide in front of you, the idea is to facilitate full-time enrollment by making sure that classes are blocked in morning, evening, or even weekend schedule so that students can more predictably schedule classes, but more importantly, they can more predictably schedule what they need to do outside of class, work and family obligations and that kind of thing, and for this to be maintained semester after semester through the life of the program. So we've been required to submit 2 block scheduling reports. This is the second one of those. And we collected student data from all of the institutions in Texas on this. And what the early results of this show is that in terms of completion, block scheduling seems to have a positive impact. And where it looks like it may not have such a positive impact is in relation to the persistence rate. And fall to spring persistence rates in 2016 and 2017 show 56%, which is very good, by the way. But if you look at the fall to fall, which is in the next slide, fall to fall persistence rate is only 21%. And at first glance, that looks like a fairly low persistence rate for students. But one of the things to point out about this is that institutions tended to block schedule both certificates and degree programs and certificates, a lot of them can be done in less than a year. And so we think that what we're seeing in a persistence rate of only 21% from fall to fall is that students have also completed within that time period, and so there would be no reason to come back in the next fall.
Any questions or discussion? Hearing none, do I have a motion to adopt the staff recommendation? Motion by Mr. Raven, second.
Second.
Second by Ms. Acosta. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. We move on to agenda item 5F. It is consideration of adopting the staff recommendation to the committee relating to a Bachelor of Science in Dental Hygiene at Tyler Junior College report. Per House Bill 3348, 84th Texas Legislature regular session. Members, you have a copy of this report with your materials. Rex.
So 2 sessions ago, Tyler Junior College was authorized to offer a bachelor's degree in dental hygiene. And they indeed set up the degree, and so this report deals with their success since then. They've had a total of 13 graduates since the inception of the program, so I would argue that they've had modest success with the program itself. And part of what's happened is we note in the blue pages of this, the regulatory and legislative environment of this has changed with the passage in the last session of Senate Bill 2118 that allows community colleges to establish baccalaureate degrees. So as a result, the pilot project has kind of gone away, if you will, and so we have no further recommendations to make.
Okay. Any questions or discussion? Hearing none, do I have a motion to adopt the staff recommendation? Motion by Mr. Wilson. Second. Second by Mr. Raven. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. Thank you. Agenda item 5G is consideration of adopting the staff recommendation to the committee relating to the report on the recruitment of persons with intellectual and developmental disabilities at institutions of higher education. This is per Senate Bill 37, 84th Texas Legislature regular session. Members, you have a copy of this report with your materials. Jarrell?
Good afternoon. This report comes from the 84th Legislature, Senate Bill 37. From that bill, it required the coordinating board to do an ongoing study on the college recruitment of persons with intellectual and developmental disabilities. Basically, through this report, we're looking to identify effective recruitment efforts and address any limitations on current recruitment efforts for this particular population. Without going through the entire definition, but you see we did have to define this for the report study, the slide. We did this through rule, where IDD is a neurodevelopmental disorder that must meet these 4 criteria that's laid out on this slide. In interest of time, I will go into what we have found in these sort of recruitment activities. We did this 2 years ago. We used a survey, had about 81 responses. Then we looked at 3 items: what recruitment efforts are out there, what are their limitations, and of course, what recommendations can we use to move forward to help serve this population. Not surprisingly, the percentages that we used a few years ago are about the same as what we found this year. Commonly cited limitations for this population, I want to point to 2 things that I think we need to consider moving forward is the inability of students with IDD to attend these activities, as far as transportation being a concern, and the last is particular financial aid that's directed particularly to this population. Recommendations for moving forward, there are a number of projects that we think are best practices, but I just want to point to 2 that we have direct impact over is maybe expanding the next project I'm going to discuss, Advise Texas, providing some additional training, working with Texas Workforce Commission to expand that to serve this population, and then obviously training our work-study mentorship. That's something we have a direct impact over to see if we can help this population. So there are efforts at a certain number of schools that are ongoing, but obviously with more resources, they're able to do a lot more with that sort of focus in that population.
Okay, any questions for Jarrell on this topic? There are no further discussion on it. Do I have a motion to adopt the staff recommendation?
So moved. Second.
Motion by Mr. Raven, second by Ms. Acosta. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. One more item before lunch. Agenda item 5H and that is consideration of adopting the staff recommendation to the committee relating to the report on the effectiveness of Advise Texas program per Rider 5385th Texas Legislature regular session. Members, you have a copy of this report with your materials. Jarrell.
Thank you. This will be the lunch version of this report. The evaluation report for Advise Texas is very positive. Just to remind you, this is one of our leading projects, providing a near-peer advisor to certain high schools that have low-income, underrepresented students. We have a number of partners in this effort, the College Advising Corps, our own foundation here, Texas Higher Education Foundation, as well as partner institutions including UT Austin, Texas A&M, TCU, and Trinity University. You will see here, and I'm giving that version, the map just kind of centralizes where these are high populations of that group that we have. We'd love to expand this, but one, we needed this report to see how effective it's been. We've been doing it for a while, so the legislature has asked us by rider to study how this project has been moving forward. Our partners, the College Advising Corps, partner with Dr. Eric Bettinger for Stanford to do a larger study of the program. This project is all over the United States, but the Texas model not only is the largest, but it's a little different. It's been narrowly tailored for Texas needs, particularly around two-year colleges and the way we do our high school graduation plan. But this was a random control trial where they looked at impact on college enrollment, persistence, pathways to college, school culture, and advisor study attitudes toward the project. The couple of findings I want to at least point out, at least last year to give you some sort of idea of impact, we served 40,000 seniors just last year alone. And from that, the 40,000 seniors completed applications, over 130,000 applications. We're in 44 school districts, and with that, over $476 million was awarded to these students to be able to go to college. Another part of that, which I think is critically important, is how the counselors reported some sort of impact, how it helped their lives. I mean, as you know, it's 400 to 1 for a K-12 counselor. In schools that had Advise Texas advisors, the counselors saw a direct impact and benefit to their work and to the students and the culture and experience there at their institution. But the middle bullet here on this slide, that 3 percentage points, that Advise Texas increased college enrollment rates by 3 percentage points, especially for low-income students, that's where we've seen the success. And if you were in the program from the beginning, from 2011, you actually 5 percentage points. So right there, that middle bullet point is about 2,000 more students that are going to college that would not have if we did not have this program in place. So in the lunch version, if you're going to get something from that, that is what I want you to see, that this is actually showing that students are enrolling and persisting better than ones who do not have this sort of project in their program in their school. The last point I want to point out is for schools that are very large, we have found that we probably need more than one advisor. There's just too many students with sort of these issues that you're already aware of, that we need more than one advisor in there. I think if we had more advisors in larger schools, we'd see a greater impact for some of these schools. And lastly, what I think around the space that we operate in, a lot of these advisors end up going into counseling. Some of them have been hired by the school district, separate from Advise Texas. So we think it has not only a positive impact for the students and the high school students that they're serving, but the graduates who might go back and get their master's and so forth, they're actually staying in the profession also. So we're excited, and we hope to share this with the legislature. They gave us, they provided $4 million for the biennium, and hopefully they'll either expand it or at least continue what we have so we can keep doing this good work.
Very good, Jarrell. The effectiveness of Advise Texas is outstanding, and those numbers are very impressive.
We're excited.
Thank you for your report. Any questions or comments for Jarrell?
Just a quick question.
Yes.
So these schools that we're in, they don't have other advisors, or does this augment or train advisors training advisors, or they just don't have anybody advising the kids?
Some of them have advisors, smaller programs. Advise Texas is a lot larger, and it serves the entire school. So while some people say I only deal with this particular population, Advise Texas serves the entire school, and obviously seniors get the greatest benefit. But some of these schools don't have any, and Advise Texas might be the only one in that particular school, other than their K-12 counselor.
Yeah, Terrell, maybe David, you're going to say this, but you had said, I guess, to the foundation, a lot of these, or somebody said, a lot of these counselors that are in high schools now are kind of behavioral type specialists, and that's their focus, is solving behavioral problems, not trying to coach people to get in, how to encourage people to go to college, how to apply, and how to apply for financial aid. So isn't that right?
Chairman Stemmons absolutely correct. They go to college to be counselors, so it's behavioral, academic, testing. That's why they're there. And with the population so large, these high schools, they don't have the ability to keep up with admissions and FAFSA and changes of that sort. So these advisors serve in that particular role and help support the counselors at these K-12 at these high schools. So it's above and beyond what the counselors would have been able to do ordinarily.
Very good. Any other comments or discussion? Okay, if not, do I have a motion to adopt the staff recommendation on agenda item 5H?
So moved.
Second.
Okay, motion by Ms. Acosta, second by Mr. Raven. All in favor, please signify by saying aye. Any opposition? Hearing none, the motion passes. Agenda item 5I is lunch. The committee will now break for lunch, and while a quorum will likely be present, no public business or public policy over which this board has supervision or control will be discussed. We intend to convene at approximately 1:35, 30 minutes from now. So we'll take a break now for lunch. Thank you. 1:35. Very good.
I'm going to be watching that game in Kansas State with a little bit more interest.
We're set? Okay, good. And we're calling again the meeting to order. It's now 1:35. Okay. Items 5J through 5N are updates and no action is required at this time. Agenda item 5J is an update to the committee on the assessment of graduate medical education positions report per Senate Bill 215, 83rd Texas Legislature regular session. Rex?
So this report is still in progress, although we're almost finished with it, so you will have it by the October board meeting.
Okay, thank you. Agenda item 5K is an update to the committee on the advanced placement report per House Bill 1992, 84th Texas Legislature regular session. Rex?
And so again, this is a report that's in progress. We received some of the data from the College Board. We usually get it very late to meet the deadline to turn this into the legislature, but we have all the data. It's been run, and we're finalizing the report now. We'll have it for you before the October board meeting as well.
Thank you. Agenda item 5L is an update to the committee on the Texas General Academic Institutions Increasing Successful Community College Transfer Report. Per General Appropriations Act, Senate Bill 1, Article 3, Section 49, 85th Texas Legislature. Rex?
And the same is true here. This isn't one that was given to us by the Senate Bill 802, and where we've looked at transfer among institutions. And what we did was we looked at institutions that were, according to students that they got through transfer to graduate, and we looked at who we thought was doing the best and worst. But we'll have all the details for that before October as well.
Thank you. Agenda item 5M is an update to the committee on best practices in the transfer of course credit between public institutions of higher education report per Senate Bill 802, 85th Texas Legislature regular session. Rex?
No, I'm sorry. This is the one from Senate Bill 802. The previous one is the annual transfer report that we do every year. But the same is true of this one. We're in the final stages of finalizing the report, and we'll have all of this to you well before the October board meeting.
Okay. Agenda item 5N is a report to the committee on school closures and/or teach-outs pursuant to Chapter 7, Subchapter A, Section 7.75. Rex?
Thank you. So as you can see, we have two institutions that are closing, Argosy University in Dallas and Strayer University in North Dallas. And they have adhered to all the requirements, teach-outs. There is one correction to be made to this. For Argosy University, who had originally told us that they would have their teach-outs completed by December the 31st of 2018, they sent us an update a few days ago, and their teach-outs will go until December 31st of 2019.
Okay.
So, but that's an indication they're taking care of the students, so it's a good thing.
Okay. Everything else good on the rest of the report?
Else is fine so far.
Okay, thank you. Agenda items 5O and 5P were on the consent calendar. Agenda items 5Q 1 through 7 is consideration of adopting the Architecture and Construction Program of Study Advisory Committee's recommendation to the committee relating on courses required for 1, architectural drafting, 2, electrical line worker, 3, industrial electrician, 4, residential and commercial electrician, 5, heating, ventilation, and air conditioning, and 6, pipe fitting, and 7, plumbing. Rex?
No, thank you. So these are all programs of study under the umbrella of architecture and construction. And in the interest of time, I will not try to go through each one of these in particular, but I will tell you that we did receive some comments on a couple of them. And if you look at the comments very closely, then what you find is that most of the comments have to do with this course doesn't meet my current program, or it doesn't quite fit with what we're currently doing. And programs of study are designed to facilitate transfer between a 2-year institution to another 2-year institution in career and technical education, particularly associate of applied science degrees. and to find some kind of common basis for those programs. I was recently at a meeting at the Railroad Commission, and someone from the energy industry was lamenting the fact that he really wished that he could hire people that had been trained by the community colleges in things like instrumentation and so forth, but he would really like it if he could hire someone from both, and he used Midland and Panola as examples of West Texas and East Texas, and he was in the East Texas oil field, but he really wished he could hire someone from Midland and Panola, and they both had pretty much the same training, because he could be assured then that they had gotten the same kind of background and had the same kind of knowledge and skills. And the programs of study are designed to try to provide some of that and facilitate that. So you'll see that the programs of study sometimes range from 20 hours on up to 40. Most of the comments revolve around, this doesn't exactly fit with our program right now, but we have left enough room in most of them for local needs courses if there are particular things that a local industry wants them to do. And we don't dictate the sequencing of the courses, which was also one of the major comments about it. But there are also a lot of positive comments in there about how this would be helpful to students, particularly if they want to transfer from one institution to another.
Mr. Chairman?
Yes.
Okay, so we have the authority to dictate, that this is a field of study, these are the courses you need to offer.
So our authority says that if a field of study or a program of study in this case is developed, then a receiving institution must accept those courses and apply them to that same degree.
So, yes, then.
Right.
Just remember, the field of study deals with the more horizontal as well as vertical transfer to universities, and this is just community college to community college.
2-year to 2-year.
So programs is community college to community college, and fields of study really works both community college to community college and community college to university and university to university.
No, exactly. So no, we request a vote of approval on each one of these, but I won't go through each one of them individually unless you have questions about it or you'd like me to address each one of them individually.
And the comments, you feel comfortable with the comments?
Yes, so one of the things to remind you of is when every one of these, after the committee adopts, it goes out for public comment for 30 days. And at the end of that 30 days, we take those comments and try to group them. They all go back to the committee as, verbatim. We don't try to dress them up in any way or anything. We try to group them sometimes and point out to the committee where there's common elements and that kind of thing. But they go back to the committee, and then the committee always has the option at that point of either changing something. There are a couple of places in here where the committee recommended that a change be made in wording or in language. But the committee has the option of either agreeing with the comments or addressing the comments of the field in some way. And typically, they rarely ever change what they're doing because, again, most of the comments revolve around, this is not the way we do it. We don't teach this course in that semester. This stuff in this course, we actually teach over 2 courses. And so most of it rarely, if ever, revolves around the actual subject matter content of the program itself, where the committees almost always have widespread agreement about that. In fact, the only time I've ever really seen a committee really get into an argument about subject matter content was actually the mechanical engineering field of study that argued about whether motors should be included in the curriculum or not, which just mystified me to no end because I thought motors was sort of the heart and soul of mechanical engineering. But and there was more nuance to that than it sounds like originally, but they really got down into an argument about whether there should be a separate course on motors or not.
Interesting.
But that's one of the rare occasions where they actually talk about subject matter content. It's almost always about we do this in semester 1 and somebody else does it in semester 2 or 3, and we do this in this course, but I do it in this course and you do it in this course. So this is a cultural change for the institutions to come together as a group and to talk about what students need to do to be successful in that field or to be successful at the next level.
Okay, great. Any other questions for Rex?
If not, do I have a motion to adopt the staff recommendation?
Chairman, I move to approve.
A motion by Ms. Acosta. Do I have a second? Second by Mr. Wilson. All in favor, please signify by saying aye.
Aye.
Any opposition? Hearing none, the motion passes. Agenda items 5R1 through 5 is consideration of adopting the Health Science Program of Study Advisory Committee's recommendation to the committee relating to courses required for 1, dental hygiene, 2, emergency medical services paramedic, 3, occupational therapy assistant, 4, physical therapist assistant, and 5, radiologic technology. Rex?
And I'll just make the same comments about this particular group. So remember, under programs of study, what we've done is we've organized these around the 16 career clusters that have long been identified by the governor's office in Texas. And one of those is the health sciences program. And so under that broad umbrella committee, then we break it into subcommittees that look at each one of these distinctive fields. And we bring in folks, the first one on here is dental hygiene. And so we bring in dental hygiene faculty from around the state to look at this and make recommendations about what the fundamental courses ought to be in that particular program. And again, the comments were pretty much the same for these, and indeed, actually less comments were received about most of the health sciences programs, but the same kind of flavor that we received around the construction trades as well.
Okay. Any questions for Rex or discussion on this? Hearing none, do I have a motion to adopt the staff recommendation?
So moved.
Moved by Mr. Raven. Do I have a second? Second by Mr. Wilson. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. Thank you. Agenda item 5S1 is consideration of adopting the staff recommendation to the committee relating to issuance of a request for applications for the Autism Grant Program. Rex?
Thank you, sir. So we're in the third year of the Autism Grant Program, which was originally conceived in the legislative session before last. It has 3 specific parts to it that deal with parent treatment care, innovative practices, and teacher paraprofessional training. And we issued an RFA back in the spring of 2018, and we did not get enough applications, and we did not award enough applications to spend all of the money available for the parent-directed treatment category. And so there's still approximately $1.8 million available, so we want to issue a second RFA to award the rest of that money. Yes, ma'am.
Rex, as you know, this is one of my special efforts, just because I have a niece who, not just for our family, but for the sake that I know that rural communities and rural areas, it's hard for the parents to drive to, a metropolitan area to get help, and so if there's anything that you think we could do our relationships in healthcare or something to just get the word out, I would be happy to help or guide in that. That $1.8 million is a lot of money that I hope that we could try to get out there somehow.
Yeah, and this is somewhat of an anomaly because we haven't had this problem in the past, so to speak, of being able to spend the money. When the grant program first started, we had as we usually do when you first start a grant program, there's more paperwork involved than you like. But once we got up and running, this is the first time we've had any issues with actually making sure that we expend the money. But we'll keep that in mind. If there's anything you can do, we'll certainly let you know.
Okay, thank you.
Yeah.
Any other questions or discussion? Thank you. Hearing none, do I have a motion to adopt the staff recommendation?
So moved.
Moved by Ms. Acosta, second by Mr. Raven. All in favor, please signify by saying aye. Aye. Any opposition? Hearing none, the motion passes. Thank you. Agenda item 5S2 is consideration of adopting the staff recommendation to the committee relating to issuance of a request for applications for the Minority Health Research and Education Grant Program. Rex?
Thank you. So the Minority Health Research and Education Grant Program was established as a part of the state's tobacco lawsuit settlement. And this particular program provides money to pursue the areas of minority health in various and sundry ways. And so this is to issue the RFA for fiscal year 2019 which just started, and we intend to focus on projects that will support clinical training experiences to students. And so one of the biggest issues in healthcare of any kind is always, where do you provide clinical training and do you have enough, and it is appropriate. So we'll be soliciting applications for that particular, cover that issue.
Rex, what's the amount for that program available?
We have about $1.5 million. The amount sometimes fluctuates because this is based on that endowment, the trust fund from the settlement. But this year we should have about approximately $1.5 million.
If there is no further discussion, do I have a motion to adopt the staff recommendation?
Second.
Moved by, motion by Ms. Acosta, second by Mr. Raven. All in favor, please signify by saying aye.
Aye.
Any opposition? Hearing none, the motion passes. Agenda items 5T, 5U, and 5V are all on the consent calendar. Agenda item 6 is adjournment. Is there any further discussion? If not, may I have a motion for adjournment? Motion by Mr. Raven, second by Ms. Acosta. All in favor signify by saying aye. Aye. Okay. Any opposed? Hearing none, motion passes. Thank you all very much and have a good afternoon.
Even beat his target number. You did well.